thank you for joining us today at the 5th edition of the CII Northern Region Healthcare Summit. We'll be starting with the inaugural session shortly. Thank you. Mr. Vikram Pagaria, Joint Director Coordination, ABDM, National Health Authority, Government of India. Mr. Shailesh Nigam, COO, AAF International, EEMEA, CIS, and SARC. Dr. Upasana Arora, Co-Chairperson, CII Regional Committee on Healthcare, and Director, Yashoda Super Speciality Hospitals. Dr. Devendra Khandet, Deputy Director, Bill and Melinda Gates Foundation, will be joining us shortly.
It's a very old thing, but I'm telling you, traffic is really very high.
I would now like to request Dr. Dharminder Nagar to please take the proceedings forward.
Good morning, everyone. Thank you, everyone who's here on time, beaten the traffic. So the audience, let me thank you first before I even start the conference. Your presence makes the conference. So welcome. Thank you for your participation and looking forward to the interactions. Today is the 5th edition of the CII North Region Healthcare Summit. We have the pleasure of having Mr. Vikram Pagaria, Joint Director Coordination, ABDM, National Health Authority, Government of India. Mr. Shailesh Nigam, CEO, AAF International, and of course, Ma'am Upasana Arora, MD, Yashoda Hospitals. Thank you for all of those who consented to participate in this. My emails have worked for some of you, if not all of you. So thank you for doing that. India is at an inflection point. I think we are at an inflection point for the simple reason I think we can take leadership in healthcare in the world. And that's going to happen through technology. Technology is the enabler for India to move ahead in world healthcare. And let me demonstrate in maybe one or two things, which may be pertinent to some of you. In the US, and some of us know and some of you know, to establish an EMR, the top 2 players will only give you a quote if the deal size is $100 million. So Epic wouldn't even talk to you if you don't give an order of $100 million. Cerner to usse bhi zyada. In India, we've broken the code. EMR, if not perfect, but as good as the American system, is available across the board, and it's just not about one company or 2 companies. I think multitude of companies are doing it. EMR is just a pointer. Then how can we move ahead of the curve? ये वही वाली revolution है कि हिंदुस्तान में हमारे पास वो फोन नहीं आए, लैंडलाइंस, लेकिन हम सीधे मोबाइल पे पहुंच गए. जब हम मोबाइल पे पहुंचे, तो when we go sometimes went to America and realized कि यार ये हमसे पीछे हैं, हम इनसे आगे हैं. इनके पास टेक्नोलॉजी नहीं है, हमारे पास टेक्नोलॉजी है. Another pertinent example of the future आप पैथोलॉजी ले लीजिए. A pathologist costs what? 3 lakh, 5 lakh, 10 lakh. And it requires around about 10 years of training to create a pathologist. At least 10 years, if not more. And the most amazing brains of the country will only get into the medicine and get into pathology and then become a pathologist. आज digital pathology हम क्यों नहीं यूज कर सकते? So when they say वो हम WHO का फॉर्मूला लगाते हैं, इतनी पॉपुलेशन, इतने डॉक्टर्स, दिस इज द हाउ मेनी पीपल वी रिक्वायर, आई डोंट थिंक सो दैट इज ट्रू. आई विल चैलेंज इट. इट एंट ट्रू. अगर हम टेक्नोलॉजी को लेवरेज करें तो हमें इस देश को इतने पैथोलॉजिस्ट की जरूरत नहीं है. यू नो, इट टेक्स टिपिकली 5 crore rupees टू ट्रेन अ MD physician here. You want to spend all that money to train these people? It's not that these doctors are not required, but they could be doing something else. So the resources can be appropriately used. These are the two things I've just left it in, parked it in your brains, that not necessarily जो हमें सिखाया जाया है, जो पढ़ाया जा रहा है कि भैया WHO का रेशियो ये है, फलाना ये है, that is how things will happen. No. Things can change, we can move forward, we can challenge the status quo. We must challenge the status quo. And this country is at that inflection point. I think G20 mein, India did an amazing job to prove to the world that how this country can take leadership. And health for all, health ke andar leadership, it's not a social, it's Ayurveda ka, yoga ka prachar is part of the healthcare enterprise. And I think all of us who come from hospital background also have to be aware and open to the fact that किसी भी पद्धति का इलाज हो should be incorporated. We are, end of the day, healthcare providers. We are not just allopathic providers, we are just not this or that or the other. This country has, for decades, tried to suppress our own forms of medicine. और ज़रूरी नहीं है वो सब चीज़ में कामयाब होंगी. Few things we can use. The cutting edge technology with our ancient knowledge is the way to the future. These conferences need to be a platform to challenge what is being the norm, what is being thought of as इसी तरीके से काम होना है. We don't have to do that. We, all of us, have to figure out a way कि okay, this was the prescription, but this prescription, let's say by WHO, ये अमेरिका के लिए ठीक है, इंडिया के लिए ठीक नहीं है, यूरोप के लिए ठीक है, हमारे लिए ठीक नहीं है. If we start building, I mean, even medical colleges, I am challenging today that maybe we don't need those many medical colleges that we are considering. बनाए जाओ, बनाए जाओ, बनाए जाओ, बनाए जाओ. डॉक्टर नर्सिंग वाला काम कर रहा है, नर्स हाउसकीपिंग वाला काम कर रही है. प्लीज हम लोगों को सही आदमी से सही काम कराना है. स्पेशली द talented people. I mean, literally the misuse of nursing in this country is like ridiculous. And we are all responsible, starting from me. I'll give you an anecdote. हम जैसे भी जब इंग्लैंड गए कुछ पोस्ट ग्रेजुएशन वगैरह करने के लिए, आई रियलाइज दैट द डॉक्टर्स तो हम जैसे ही थे, गुड, बैड, अगली एंड यूजलेस लाइक मी. But the great difference in healthcare was the nursing care. They were empowered, they were leading the charge, they were actually running the protocols. तो डॉक्टर की अहमियत उतनी ही थी. So इस देश में maybe we don't need so many doctors if we do job appropriately, define what needs to be done when and who needs to do what. At CII, both at our national and regional level, we have lots of conferences and lots of interactions, and a lot of output comes out which enables governments to make the right decisions. बिना हमारे interaction के, बिना इस platform के, I don't think government will also be able to make the right decisions. We must participate more, come out with effective strategies, call to action. It's important we come out with call to action. The CII people who work behind the scenes, thank you so much for your hard work. Without you guys, this won't be possible. हम तो आके lecture दे देते हैं, but it's your hard work, it's your organizational skills, and it's your representation between private and public participation. You guys are the enablers, so thank you very much. Without further ado, बहुत कुछ मैंने बोल दिया. Could I request, ma'am, for you to take the stage and carry the कार्यक्रम forward? Thank you.
Good morning, everyone. First of all, I am very sorry that I am late. But you know, when Dharmenji, who is a young leader in healthcare, he is there, so I was quite, now it's high time to, seniors to take a back and, listen to them. Our secretariat has given me some talking points, like unfortunately, I am not used to present PPT, as well as I am hardly looking at the papers. So whatever I would like to say, I will say. So sometimes I become more emotional, so please forgive me for that. This is a healthcare summit, and I think now everybody knows that how important health. After Corona, at the time of Corona, all businesses were just stopped. Everybody was sitting at home, and we were really scared what will happen to us. So that is how we can learn this thing, that how important health is. And who is providing health? Healthcare providers. If you are not feeling well, then you are trying to get some advice from your doctor or your nearby hospital and all. So now healthcare industry is changing rapidly. As Dharmenji was telling, that technology is taking actually place instead of all the time manpower, especially when this artificial intelligence is really playing a major role. As you can say, especially in the field of diagnostic, artificial intelligence is now, after I think 15 years, after 15 years, hardly radiologist will get any work. They will actually do intervention radiology. Other things, these machines will tell what is your diagnosis and what is your problem in X-ray, in other things. So when healthcare industry is changing rapidly, so we need to adopt it. And all those who are taking services from healthcare, they should understand that this is the only way, that we need to see all the innovations. And you can, these days, lots of conferences are happening, and in these conferences, what we learn, we are actually learning from each other's best practices. All the hospital who are, showcasing their innovations or whatever best they are doing, which is a very good thing. I think everybody is doing something new in their own field. As well as if we talk about government, government is also very much interested to make our infrastructure very strong. As Dr. Dharmen was telling us, ki medical colleges, so I think DNB is better than medical college, because in DNB, doctors are learning bedside. And for a doctor, it is always very important that they should learn from the experience, not from the books. Because when you are learning from that is why Indian doctors are the best doctors in the world. I would like to share my experience with all of you. I was in USA with my husband for some, because we are doing something. So we were there for some work. My husband falls sick, And I have not wasted half an hour. After half an hour, I just visited a hospital and we got admitted there. You won't believe my experience in the US best hospital. I don't want to quote name of the hospital, but that was called best hospital. And I have faced horrible experience. I was sitting on a chair for 18 hours in emergency. There was no bed available. And there was no even washroom. They have given me a bottle for urine, that you should do it. He has to pass urine in this. If any of us, Dharmenji will agree with me, if any of us will do like this, nobody is going to spare us. And after that, because my husband was, he got he got dengue, but they were not aware about dengue. And so there was no lab available, so they have sent his sample somewhere else. They started treating him for blood cancer because his WBC count was very low. Because I belong to healthcare and I have a team of doctors, so I have given all the reports to my doctor, but they were not understanding anything. And whatever I am telling you, it's strange that I was used to change my bed sheet of my husband's bed. I was used to call for everything. I was used to go outside on the nursing station and I was asking everything. No one was visiting us. So this was the scenario. In our hospitals, I am talking about all private hospitals, what we are doing, we are providing best to the patient. We all are, our staff is always one call away. So anyhow, picture was, then my team went there, all the doctors went there, and there was a big discussion that it's a dengue. Anyhow, after 17 days of stay, he was really very, very sick. He went into multiple organ failure, this and that. I could save him with the help of an Indian doctor who was there, because he was actually needed some medicine, and they were not understanding the, what is happening in Indian industry, Indian healthcare industry. We understand the emergency, and we react on this. And there they are so cool, they were just making panels and talking, but not giving medicine. Because I think they are scared of suing of the doctors, because in America it's a big challenge that all the time, all the doctors are sued. And when we went, anyhow, things went well, and when we were coming back, then they told me it was dengue. Report came after 21 days. Can you believe this in India, that we will get report of a dengue after 21 days? We are to releasing report in 2 hours. So this is the strength of Indian industry, Indian healthcare industry. That is why we are more focusing on medical value travel. So other countries who are actually not able to provide healthcare on time, we are promoting our nation. So, and like pathology, like radiology, like teleconsultation, we can remove our manpower and we can provide efficient diagnosis as well as treatment to our patients. And CII or other councils are playing major role, because when government is making any policy, they are always asking us that please give us some points what we are supposed to include in our policy. So you people who are sitting here are playing a major role, because whatever discussion we will do, we are going to write it. That if I am saying something, and all my respected panelists will, because now session is going to start. It's a long list which I am supposed to speak. Bhupinder is going to be angry with me that madam is not speaking whatever I am telling him. So because CII, we are representing CII Northern region, and Northern region is all the time doing some activities, and not only activities, we are trying to, keep all our stakeholders together. Like you people are here, and we are already doing many other activities. With these activities, what is happening, you are listening something new here, and you are going to tell all this thing to some other person. That is how industry is going to, spread their words everywhere. So today's conference is going to be very interesting. All panelists, all speakers who are coming to speak here, they are very knowledgeable. So keep your pen and paper ready, listen to them, note down whatever you like, or you can click a picture. These days it's a very, I though always do whatever I like, I always click a picture, because when you write, half of the time you are writing only 2 words and other things you are missing. So with these words, most welcome, sir. Please have a seat. Good to have you here. I am going to stop my speech, and most welcome all of you. And thanks to CII for making me part of this tremendous, adventurous, interesting, whatever good words you can include event. Thank you so much.
Thank you so much, ma'am. Your personal experiences have given me 2 ideas. We should ask the government to raise prices for us. We should renegotiate with our insurance companies. And I think Indian healthcare, you clearly demonstrated, is at the cutting edge. We are doing great work. So in your own personal experience, you've demonstrated that Indian healthcare or private healthcare is doing tremendous work in this country, and we need to tell more and more people about it. So thank you, ma'am, for sharing your personal experience. Could I request Shailesh Nigam ji to address us, please?
Good morning, ladies and gentlemen. Dr. Dharmender, Madam Upasana, and other fellow dignitaries on the dais. As ma'am mentioned, she likes to speak extempore. I also prefer to speak extempore. But in front of such an important and august gathering, I wanted not to miss my thoughts, so I prepared a speech. And a very spirited welcome to all of you on this CII Healthcare Summit. And in fact, I am thrilled to be among such august gathering of healthcare visionaries. As we say, learning never stops. These platforms have always been a place of knowledge enhancement by exchange of ideas, by sharing thoughts, by having expert opinions. So today I want to stir your thoughts and emotions by taking you on a journey through the air we breathe indoors. Let me ask you a question. Are you truly conscious of the air you inhale when you're indoors? We go about our daily routine, oblivious to the invisible world around us. After all, if the air looks clear, we feel it is healthy, correct? And that is what we feel, we know, we perceive, right? But the truth is quite different. Indoor air quality is a silent but a very powerful influencer on our health and well-being. We live and work indoors for a significant portion of our lives, and the air we breathe has a profound impact on our lives. It is well documented that 90% of our life we spend indoors. So it's like 72 years for a person of 80 years of age. We take almost 1,000 breaths every hour. So in a day, we breathe almost 2,000 gallons of air. And to understand what is 2,000 gallons, it's like a normal size swimming pool. And it's almost the amount needed to oxygenate approximately 2,000 gallons of blood pumped through our heart. So we are very mindful whenever we are eating something or drinking something. We look at the packaging, we look at the brand, we look at the certification, the expiry date. We are always very thoughtful, very mindful whenever we are consuming something. And normally we drink maybe half to 1 gallon of liquid every day, 3 to 5 pounds of meals every day. And compared to that 2,000 gallons of air which we breathe, we don't even bother. We don't even bother till we see the haze outside. Then only we see there is a pollution. But actually, the air inside can be much more polluted than outside. What we don't see, and this is what, it is invisible. So even in the spaces that seem pristine, the invisible threat hangs around us. Pollutants, allergens, bacteria, and contaminants fill the air and quietly affecting our health. Many of us in the industry, I belong to HVAC industry, heating, ventilation and air conditioning industry, and currently I'm representing AF, which is American Air Filters. So we have been preaching about the importance of indoor air quality for years. However, it really took a pandemic to elevate the level of awareness and has given the industry a platform to further educate and ultimately deliver the solutions which can improve the level of health and well-being of the people in the society. It is high time we pay attention to what we breathe. Indoor air can be 2 to 5 times more polluted, more contaminated than the outdoor air. My colleague during the day would be coming with more insight, with technical details on this. So I'm just touching on the subject. So while we are discussing, about the indoor air in the enclosed spaces, hospitals, nursing homes, diagnostic centers, labs are not the exception. Poor indoor air quality breathes life into airborne threats like bacteria, viruses, triggering the rise of hospital-acquired infections. Now let's dive into the pressing concern, airborne hospital-acquired infections. Hospitals, the sanctuaries of healing, sometimes unintentionally become the breeding grounds of infections for patients as well as healthcare providers. The rise in airborne hospital-acquired infections is alarming. Airborne pathogens increase infection risks, especially for vulnerable patients. Insufficient ventilation, contaminants, cross-contaminations through air, fungal growth, all pose risk for staff, patients, and visitors alike. We go to hospital to recover and heal those in need, not to live with additional ailments. It is our duty as healthcare providers and leaders to ensure that air within the healthcare facilities is as pure as the intentions of those who are working there. Preventive care and well-being of people must encompass every aspect of healthcare, including the air we breathe. By embracing advanced air filtration systems such as pioneered by AF, we can take a giant stride towards preventing infections, enhancing health outcomes, and creating environments that are safe for all. At the end, let us keep this question at the forefront of our minds. Are we thinking of air we are breathing indoors? As we journey through the discussions and insights of this summit, I appeal each one of us to make indoor air quality a priority in healthcare. Together, we have the power to not only heal, but also to protect. Once again, thank you, and I eagerly anticipate the transformational discussions going ahead throughout the day. Thank you very much.
Thank you, Shaileshji. You're absolutely right. None of us think about indoor air quality. हमारे point of view से तो it doesn't exist or exist. As long as it appears clean, we are happy about it. I think I would request more active participation, engagement, and knowledge transfer by people like you to us. It's important. And I think all of us, if not most of us, are ignorant about these things. Could I take this opportunity to invite Dr. Devendra Khandet, Deputy Director, Bill and Melinda Gates Foundation, to address us and enlighten us about what the foundation is doing and how the Indian healthcare system can be transformed. Thank you.
Good morning. Thank you, Dr. Nagar, for inviting, and thanks CII, all the panelists on the dais and friends of the dais. First of all, my deep apologies for being late. I think when we are speaking about the healthcare at a holistic level, I do have some thoughts as a public health practitioner. For more than 25 years, I have not personally, independently treated patients. At one point of time, I used to take pride in being a curative physician, but for more than 2 decades, I am a public health practitioner. So some of my thoughts may be more skewed towards the public health practice rather than the curative one. I represent Bill and Melinda Gates Foundation, and BMGF works in health, nutrition, urban sanitation, agriculture, financial services for poor, gender, and empowerment of women. Some of these are the broad areas about which we work. Within India, our 2 priority focus states are Uttar Pradesh and Bihar. I have an opportunity to lead the foundation work in our priority states of UP and Bihar. And that's why most of the time Patna and Lucknow becomes my second home, just by the nature of that work. Some of the areas within the health space, we primarily work on, say, primary care and secondary care. Tertiary care, we generally feel we don't have the expertise, and that is reasonably well taken care by multiple organizations and multiple institutions. And India has got some of the finest tertiary care hospitals. So we are not into that space. And some of the thematic area which we focus upon are overall family health, the SDG space, maternal mortality, neonatal mortality, under 5, nutrition, etc., infectious disease, immunization. But I think we are also deeply involved into the health system strengthening and health system reforms and quality of care. And because we believe that our primary driver is impact at scale, our primary stakeholder is the government. And that's why we closely work with both the state government and the national governments in support of the government vision. And that's why Gates Foundation will never you will never hear, oh, we do have some IMR goals or MMR goals. It is the government of India's goals or the respective state government goals, towards which with With that intention, we partner and then we work upon it. And I was thinking, what should I speak to this August gathering? And I was thinking, can I share my few reflections about the resilient health systems? And we have just gone through the one of the century or probably more than century, a horrible pandemic, and many of us or probably every one of us is affected in some or other way. I think pandemic taught us the importance of resilient health system. And when I say resilient health system, it cannot be only government or only private. One has to see in totality, because both players, and if I can use the word, the state health system as well as the private players, they bring a specific expertise on the table. And how do we look at in a holistically, and how do we create a win-win situation? And that can be the hallmark for, and that can be important recipe for a successful, resilient, vibrant health system. And when I say vibrant and resilient health system means, and my definition is very simple about resilient health system, a system which has got the ability to bounce back irrespective of the damage it is being done at that point of time. So COVID put a shock on the system, but how quickly that system bounced back, and does it work in as if nothing has happened? That's the characteristic of resilience, and how the resilience will come. And I think there is a vast literature and the vast experience around it, and generally it is said, okay, you focus on few building blocks, say human resource for health. You have got a sufficient number, there is a skill and they are skilled and competent, and there is an enabling environment for them to perform. If you take care of these three, HRH issue is solved. Of course, there are layers and layers and layers there. But, and so a resilient health system will have a strong human resource. And many times we talk about human resource only from the lens of, okay, I do have X number and the X. And the question is, are they skilled and competent? Yes, I do have skilled HR also. And the third question is there an enabling environment where they can thrive? And because whether you are working in the NICU or operation theatre or general OPD, it's a teamwork. And whether the specialist doctors and the general practitioners and the nurses and the paramedics are skilled and in a way unified for that vision. And all this will constitute towards the human resource for health. Second is no brainer. These are all simple: supply chain and logistics. And for a pretty long time, many states had a challenge in having a last mile delivery of the drugs and diagnostic. Because finally, one of the factor which will decide the trust in the system will be the availability of the HR as well as availability of the drugs and the diagnostic. And there are a lot of efforts that are being done, lot need to be done, but I think that is one area. Of course, the dollars and the finances and the facility strengthening and the outreach strengthening, these are all given. But I think one of the thing which combines everything is the data for decision making. Everything is there. Many times our one of the challenge which we face in a resilient health system is a siloed behavior of every vertical. Are they speaking with each other? Is a decision maker is in a position to look at everything and take a opinion based on all the variables on the field? And this is typically the data for decision making, and that's where I think the triangulation of a data, interoperability of the data, my app versus your app, and that all issues come up. Oh, I define the quality and my definition and your definition are different. And how do we think about this interoperability of data, transparency of data, and so that we can create the exceptional report which will help the decision maker to take the decision. I think that is where some of our work is happening along with the government, and I think to me, if that happens at a in both government and private, that can be. And I will give you a very powerful example. So, for example, in the COVID times, and I will take the example of Uttar Pradesh because I work very closely with Uttar Pradesh and Bihar. There was a COVID unified digital platform. And with all the humility and the modesty at my level, I can say that that was one of the best unified disease surveillance or disease management portal that was available at that point of time. And what it had is, it has a linkage with the hospitals to the laboratories, the governments and the private and the community and the tertiary facility and the secondary facility. Sometimes a lab is giving report in a private facility in one distant corner of a district, and one can easily, and before even the district authorities know, somebody can triangulate that data. And at that point of time, the UP leadership decided that this will be accepted as a single source of truth. For all this COVID management and all this, there is not a single paper which is there. It is all based on this. So I think many times we do the digital, we take digital as a lever, but we do half-heartedly. By the way, you use the app, but I will also use my papers. I will take another example. There is, and it is available on the Play Store, something called as UPKSK, Uttar Pradesh ke Swasthya Kendra. What is it about? It is about interoperability between the multiple data points like human resource for health, there is a HRMS, and in supply chain there is a DVDMS, and then there is a data management of the outcomes and the processes, etc. All these are triangulated at one point of time, at one place called as UPK Swasthya Kendra, where the exceptional reports are generated, and one can see that yes, and I have seen some of the top bureaucratic and the political leadership taking the cognizance based on this data and reporting to the district what is happening in your district and all that. So many times the more than 5,000 to 6,000 sub-centers and the health facilities are created based on the report of this. And this is happening both in UP and Bihar. For example, in Bihar, there is something called as Command Control Center, HOPE, which provides that. Lastly, I will say, as a public health professional and who was a clinician at some point of time, many years back, I feel finally at the end of the day, patient is a king. And my dream as an Indian, as a health professional is, at some point of time, there will be a time where I as a patient will decide, based on the multiple data points which are available to me, that I will choose which hospital to go, whether it is a government or the secondary or the tertiary, and there will be a clear purchaser provider split. There will be a stewardship of a regulator, but clearly distinction between a purchaser provider split, where I as a consumer, that is a patient, will have the ability to say, I am going to this hospital because it will cost me this much, because this is rated like this, because the hospital infection rate is like this, and because the waiting time is this much, and because the quality standards are like this. This is a dream towards which I think I am aspiring for that day where, and there are multiple pieces moving in that direction, but I hope that will come sooner. With this, I once again thanks Dr. Nagar and entire team, and thank you so much.
Thank you, Dr. Devendra ji, for your impassioned speech and aligning all of us in one direction. Patient comes first. How can we leverage digital technology? And you've given us succinct examples of government using those digital platforms. All of us proactively must participate in these platforms, voluntarily participate in these platforms. One humble request, Bill and Melinda Gates foundations and foundations like these work all over the world, right? Why do we have to reinvent the wheel all the time? आप best practices across the globe हमें क्यों नहीं सिखाते जो हम government के साथ interact करके बता सकते हैं उनको? You can be our knowledge partners. You're working in Africa, you're working, and everywhere there is some great work happening. ऐसा नहीं है कि हम ही intelligent लोग हैं, or the Americans are the only intelligent people. We can find these best practices, and people like you must transfer that knowledge to us and the government of India to enable us to make these decisions faster, do the right job at the right time, at the right cost. So thank you so much. Won't take much of your time. I would like to request Mr. Vikram Pagaria, Joint Director, Coordination, ABDM, National Health Authority, Government of India, to address us. Thank you, sir.
Good morning, everybody. Thank you, CII, for inviting us. Mr. Nagar, Upasana ma'am, Devendra ji, Prashant, and the CEO from AAF. Good morning. I just wanted to talk to this August gathering about the Ayushman Bharat Digital Mission, and to be very honest, the fact that we are participating in conferences like this is because of the fact that we understand that there is a need for awareness about what the work government is doing in digital health. We are increasingly trying to make available information in public domain about the kind of work that is being done in digital health by the government, and also as was mentioned by Mr. Nagar, to partner with all the stakeholders in this digital health in the healthcare ecosystem to seek feedbacks, to seek suggestions, inputs. We have come up with various consultation papers and have sought public consultation about this. Before I try to tell you more about what the digital health mission is, I would just like to take a step back and explain to you about what Ayushman Bharat is. Ayushman Bharat scheme that has been launched by the government has four main components. It has the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. It has the Ayushman Bharat Health and Wellness Center. It has the Ayushman Bharat Health and Infrastructure Mission. And the fourth and the most recent one is the Ayushman Bharat Digital Health Mission, or Ayushman Bharat Digital Mission. Ayushman Bharat Digital Mission was earlier known as the National Digital Health Mission. So its name has been changed to Ayushman Bharat Digital Mission. I'll just explain to you about all these four legs in one or two sentences. The Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, I think all of you would be aware of, is the 5 lakh insurance scheme which is provided to the most economically challenged section of our society. The Ayushman Bharat Health and Wellness Center is a concept wherein rather than on treatment, the focus is on prevention, where health and wellness centers, about 150,000 of those have been set up in the country, and which would be the first centers where people would go and get screenings done or get teleconsultations. The Ayushman Bharat Health Infrastructure Mission, it was launched during the COVID time, which was focused on how to augment the infrastructure in government hospitals, how to create better testing facilities in government hospital, how to make them digital, provide them software. And the fourth mission with which I am associated with and with which I would want to talk to you in more detail is the Ayushman Bharat Digital Mission. The Ayushman Bharat Digital Mission, unlike the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, is a universal scheme. It is applicable to 140 crore citizens of our country. It is universal. It does not provide any financial benefit. So what does it provide? It was launched in 2020. In August 2020, it was launched first as a pilot in the 6 union territories of India, and then it was nationally launched in September 2021 all across the country. What is its focus on? Ayushman Bharat Digital Mission is focused on a word that was used by some of the speakers also. It is focused on interoperability. And with my experience in National Health Authority, one of the thing that we constantly find a challenge is that people are not able to understand what exactly the mission wants to do, what it wants to do in interoperability. And I am working in the National Health Authority since May 2021. But to be very honest, when I joined in May 2021, it took me about 3 months to understand what exactly is the mission and what exactly it is not. So I use this example everywhere I go to tell people what this mission is through an example. The example is like if a person goes to say Paras Hospital and the doctor asks, क्या मैं तुम्हारे पुराने पर्चे देख सकता हूँ? And the doctor has a computer screen on his front. Patient बोलता है yes. जैसे ही वो yes बोलता है, उसको yes जो है वो अपने मोबाइल पे बोलना है. तो डॉक्टर वुड इनिशिएट अ कंसेंट रिक्वेस्ट कि क्या मैं आपके पुराने रिकॉर्ड्स देख लूँ, और पेशेंट के पास उसके फ़ोन में अगर उसके पास स्मार्टफोन है तो उसके ऐप के ऊपर उसको यस बोलना है, या फिर उसके पास अगर फीचर फ़ोन है तो वो अपने OTP बता के अपना कंसेंट दे सकता है. एंड एज सून एज द कंसेंट इज़ गिवन, द डॉक्टर इज़ एबल टू सी ऑल द पास्ट रिकॉर्ड्स of the different visits that the patient has done. The patient is also able to manage कि मुझे मान लीजिए कि दांत का दर्द है तो मैं अपने डेंटल रिलेटेड रिकॉर्ड्स दिखाऊंगा, मुझे मेरे साइकेट्रिक रिकॉर्ड्स नहीं दिखाने हैं तो कितने टाइम के लिए दिखाना है, दैट ऑल्सो फ्लेक्सिबिलिटी इज़ देयर विद द पेशेंट. दिस वुड बी वेरी यूजफुल. Let's say for example for migrant laborers, many of the times they go to their homes or they are not there at the place of their residences, or people like us who travel a lot and we would not be able to keep all our records physically in place. With this use case, this mission has been launched. It is about creating an interoperable health system. अगर आप आज अपोलो हैदराबाद में जाते हैं और अगर 1 महीने बाद अगर आप अपोलो चेन्नई में जाएंगे या अपोलो दिल्ली में जाएंगे, एंड इफ़ यू से योर UHID नंबर एंड इफ़ यू हैव विजिटेड अपोलो हैदराबाद, द अपोलो दिल्ली हॉस्पिटल वुड बी एबल टू सी योर रिकॉर्ड्स बिकॉज इट इज़ अपोलो. व्हाट ABDM इज़ ट्राइंग टू डू इज़ facility A, facility B, irrespective of whether it is a government or private, it tries and links all the facilities and makes data exchange easy. In addition, there is one more very important aspect of this mission is that there is no storage of records. The government does not store any records. So, for example, the consent is given, the record from say Yashoda hospital moves to Paras Hospital, and we just enable that exchange. We just say कि हाँ इसने yes बोला है तो वो चले जाएगा. We will not store any records, and that is, I think, the beauty of this mission. The mission is about 2 years old. मुझे एक चीज़ जो हमेशा लगती है कि डिजिटल हेल्थ इज़ अ मैराथन रेस, like the financial sector, wherein UPI has done extremely well in the financial sector. We have been able to use UPI and achieve billions of UPI transactions. In the healthcare space, particularly in the public hospitals where we work, there is a lot of groundwork that needs to be done. At many places, we don't have sufficient hardware, we don't have internet connection. The patient load is so huge that the doctor says that if you want me to write digital prescriptions, I will not be able to handle 400 patients a day. So you provide me a man or a resource who will write for me. So it's challenging, and that is why there is a lot of scope of innovative tools like the voice to text, the OCR, wherein the doctor would still write on a paper which would become immediately digital, or writing on tablets. However, there is a lot of work that needs to be done on this. National Health Authority is trying to incentivize the use of digital technology, the use of HMIS or EHR or EMR. In January 2023, we have launched a digital health incentive scheme, wherein if a hospital makes digital records which are interoperable, we would provide them financial incentives of rupees 20 per digital record, and incentives up to rupees 4 crore can be given to a health facility. We have received a reasonable response after this scheme. However, a lot needs to be done. As I mentioned, all of you who are here, they can look at the stall that we have launched. We have set it up here. Our team is here. You can ask questions. If there are any input suggestions, you please let us know. If we can use the power of technology to alleviate the sufferings or the pain points that a patient suffers while accessing healthcare, that's the mission. That's the mission's the main aim. One of the things that we have done recently and which we are very proud of is an initiative that was launched last year, and yesterday we have achieved a milestone of 1 crore quick OPD service. So what happens is that this was typically for government hospitals where there is huge crowding. So when there is huge crowding at the registration counter, what happens is that whenever a patient goes, they have to say your name, your age, your mobile number, your address, and then you say you want to see an ophthalmologist or a orthopedician. What we have done is, there is something which you might have heard of, is called an ABHA number. ABHA number is like your Aadhaar number. It has your demographic details, it has your name, it has your gender, it has your birth details, your address. So you go to a public hospital and there is a QR code over there, and you use any app. You use Arogya Setu, you use our ABHA app, you use Paytm, you use Briefcase, you use Eka Care, or 10 other apps. You go there, you scan the QR code at the public hospital, and immediately you will get a token number 42. So So when 42 number is displayed at the counter, you go at that counter and you merely have to say that कि आपको किसको दिखाना है, because all your demographic details have already been transferred through the app to the HMIS or to the EHR. And we have seen that this uptake in public hospitals, particularly in Uttar Pradesh, has been phenomenal. And I would request if you can visit one of the public hospital in Uttar Pradesh, or RML or Lady Harding or Charak Hospital, or AIMS Delhi in New Delhi, you will be able to see the power of technology in alleviating the sufferings. There are a lot of old people, lot of women, and lot of people in problems who are there and standing in long queues. So if we can use technology and solve the various problems that a patient suffers during his or her journey to access healthcare, we are trying to solve them. So with these comments, I'll pause, and I will request everybody to please visit our stall. If you are using, if your hospital is using an HMIS or a digital system, you can please get in touch with us, and we will try to make your HMIS compatible with our Ayushman Bharat digital mission, and we will like to assist you in becoming interoperable. And if your hospital does not have a digital system or an HMIS, I would strongly recommend that you use one. Thank you. Thank you.
Thank you, sir. Your mission is our mission. Digital health is the only way to go. I can assure you, each one of us in private sector is eager to participate. I believe that the government of India has the right intention, the right idea, the right leverage. Hopefully, some more money behind the idea, because digital health doesn't happen in isolation, it also requires funds. UPI का सर आपने example दिया, some cost of UPI transaction is borne by operators, governments, banks. Customer doesn't have to pay for it. आज की डेट में अगर हम digital records रखते हैं, the hospital is paying for it and nobody is reimbursing us for that. It was music to my ears. You said कि you can apply to get ₹20 per medical record और 4 crore तक. Sir, वो scheme ज़रूर समझा देना हमें. I'll just after this, we'll be definitely requesting, and people are, I can see some audience also wanting to swarm up to you and trying to figure out how to get this access to this money. It's been a fantastic morning session. Variety of opinions from different angles, but one goal. Health, access to health, treating patients, creating an environment for healthy Bharat. Each one of us, in a small manner, is contributing to this mission, and we assure you, from this CII platform, both government sector, private sector, will work together to ensure healthy Bharat in coming decades and lead, I'm saying lead the world in healthcare statistics, healthcare outcomes. Before I end this session, it's my duty, and I would like to thank from bottom of my heart people who've sponsored this event. बिना आपके ये कार्यक्रम पॉसिबल नहीं है. Marengo Asia Healthcare, BPL, Shayadri Hospitals, Digital Health News, AAF India, and our knowledge partners, IQVIA. Thank you, all of you. Please continue to support us. These events won't happen if you don't support us. I will keep pestering you. I hope you don't mind mails, but I request that you keep supporting these initiatives. CII works very, very hard to put these things together, and आपके support से ही ये सब हो पाता है. Without further ado, I have a fantastic panel discussion coming on. We are excited, innovation healthcare, and we have fantastic panelists. I think people who are actually creating the innovation are part of the panel. आप लोग कहीं मत जाइएगा, इस panel discussion को ज़रूर सुनिएगा. I will also love to hear from the people who will be on the panel. Excited about it. Thank you so much.
I would like to request everyone to please stay on the dais for a little more moment. I would like to request Dr. Dharmendra Nagar and Dr. Upasana Arora to kindly present a token of appreciation to our speakers on dais, please. To Mr. Sailesh Nigam, COO AAF International, EEMEA, CIS and SARC. To Dr. Devendra Khandet, Deputy Director, Bill and Melinda Gates Foundation. To Mr. Vikram Pagaria, Joint Director Coordination, ABDM, National Health Authority, Government of India. I would like to request Dr. Dharmendra Nagar and Mr. Prashant A.N. to kindly present a token of appreciation to our co-chairperson, Dr. Upasana Arora, co-chairperson, CII Regional Committee on Healthcare, and Director, Yashoda Super Specialty Hospitals. I now request Dr. Upasana Arora and Mr. Prashant A.N. to kindly present a token of appreciation to Dr. Dharmendra Nagar, Summit Chairman and Chairman, CII Regional Committee on Healthcare and Managing Director, Paras Health. We begin with the next panel discussion, Innovation Transforming Hospital Operations. Right now, just allow us 2-3 minutes for the changeover. We begin with the session immediately. Thank you. Begin with our next panel discussion. The panel discussion is on Innovation Transforming Hospital Operations. May I kindly request on stage our moderator for the session, Dr. Dharmendra Nagar, Summit Chairman and Chairman, CII Regional Committee on Healthcare and Managing Director, Paras Health. Dr. Rajiv Singhal, Managing Director and Group CEO, Marengo Asia Hospitals. Mr. Rahul Mehra, CEO, AWL India Private Limited. Ms. Viji Varghese, Hospital Director, Manipal Hospitals, Dwarka. Mr. Atul Sharma, Senior Manager Sales, Hindustan Syringes and Medical Devices Limited. and Captain Ishan Khullar, AVP Business Development, Sky Air Mobility. I request Dr. Nagar to please take the proceedings forward. Thank you.
Good morning once again. I'm really excited about this session because we have a very, very diverse panel. A panel that has actually executed stuff. It's just not about talking points. They've done stuff. Innovation transforming hospital operations, effective service delivery, quality of care, patient experience, supply chain, innovation in every and each aspect of healthcare delivery. We have the pleasure of having on panel Rajiv Singhal ji. He's Managing Director and Group CEO, Marengo Asia Healthcare. And again, he's somebody who's creating a unique, innovative platform. So, सबसे पहले, what he's doing is in itself an innovation. So I think you are most apt to speak about innovation. We have, of course, Vijay, Verghese. You, ma'am, are running a hospital. You're operating a hospital. You come from a system which is already established for so long. How do you bring innovation into an existing setup? See, working in a new setup where you start off, maybe slightly easier, maybe more challenging, but more easier. But working within the boundaries of existing 50-year-old organization, 40-year-old organization, and then creating innovation, I think that's perhaps a bigger challenge. Ishan Khullar, AVP Business Development, Sky Air Mobility. You have a unique blend of expertise in aviation and logistic industry. And logistics was never considered part of healthcare. We were never actually thinking about healthcare, logistics in the same breath. Supply chain का तो हमें मतलब भी नहीं पता था. I thought things come to the hospital and we just do the patient care. COVID exposed all of our big gaddhas, let me put it this way, in supply chain. We all had to wake up to the reality of supply chain. Sky Air Mobility, you've joined in 2021, and we'd love to hear what is that innovation you're bringing to the table. We'd love to hear from Atul Sharma ji, Senior Manager Sales, HMD. Everybody knows about HMD. We'd also love to hear what happened in COVID with you guys on the supply side. Since then, what have you done? What innovation have you brought? Here, supply side constraints hospitals go in terms of not only pandemics, but in regular supplies also. How can that be managed? So, I haven't given you tall introductions for all these people, but I think their conversations will leave an impact on you. I'm very sure about it. And their words are more important than their CVs. Without further ado, let me go and start the session by requesting each one of them to put their thoughts forward for 5 minutes, and then we'll open the discussion for audience to ask them any questions. Thank you. Would you like to sit or stand or talk? Up to you. Lekin we are all eagerly awaiting your words.
Thank you, Dharmendra ji. Always a pleasure to connect with you, and it's always good learning whenever we connect. I think it's a great interaction and camaraderie which works between two of us. So thank you for inviting. Esteemed panelists here and the August gathering. Very interesting to see that Mr. Ishan Khullar comes out from the aviation industry. I'll give you two anecdotes before we start on the journey of innovation. I don't know how many people are aware that when Dornier aircraft, they were basically going through their innovation, they realized that there is a crack in their fuselage because of the sound waves which are generated because of the air engine turbine. That particular discovery gave birth to lithotripsy. Okay, scientists all over realized that if that fuselage can actually create the dent, then how not stone can be broken by use of that sound wave. That was the innovation. The second example I would like to quote, we all know that light travels in straight line. But when people were trying to develop endoscopes, the biggest challenge was when the endoscope actually gets into a curve of the intestine, the light gets obliterated. The Johns Hopkins and NASA, they were working, so NASA had worked this technology of basically creating the endoscope to take the pictures when they were looking at these space missions. And then they realized that the fiber optic cabling is one thing where they can get the light reflected in the straight light. Then NASA and Johns Hopkins worked together to create that rod lens system, and the endoscopes are today the future, and they are mainstay of gastroenterology. That is where the innovation and the ideas have come together from various industries. So as Dharmendra rightly mentioned, there could have been, in fact, not a much better panel than people having from different streams and trying to talk about innovation. And I think today I would say I'm the odd man out in the entire panelists, where I'm a doctor by profession and I'm created a healthcare organization and trying to learn. So there is too much to learn from you guys, and would love to hear from you from the innovation perspective. Having said that, Meringo Asia hospitals, just one line brief, we are 1700 beds, 5 hospitals in 2 years' time. We have hospitals in Ahmedabad, Bhuj, one we are declaring in Rajasthan and 2 in Delhi. And most important, when we created, we said, whatever decision we will take, whether in terms of innovation, technology, digital, this space, it has to benefit the patient. In that particular spirit, we said there is innovation which is happening, and I'll give 2-3 examples what we have accomplished in last 2 years. In our Ahmedabad hospital, we do large number of heart transplants. We have done around 45 heart transplants till now. But we said how we can actually, there are 2 ways, whether we want to become a leader by number, saying that I want to be the first one like Sachin Tendulkar and achieve the number of centuries, and what innovation can be done. We tied up with a Barcelona-based company. They are into blood management as far as the innovation is concerned. So we did our first heart transplant without even single drop of blood transfusion. First time in Indian healthcare, first time outside United States. We are the first ones who have done this only by sheer innovation, technology, using AI, using the correlations which actually happen, and we were able to discharge the patient in 12 days after heart transplant. This is the strength of innovation you can imagine. 12 days, heart transplant patient discharged without even single transfusion. That is what we have done from the innovation perspective. It took us around 6 months to change the ecosystem, to make consultants understand what this process is, set up the process protocols, create the entire ecosystem, and work with the partners, get the entire technology into the system, and then what we have done is this particular aspect of doing the bloodless heart transfusion as far as this thing. Now we are extending it to the liver transplants and the pediatric cardiac surgeries. That is innovation, because we will be able to reduce the average length of stay for the pediatric cardiac surgeries. Blood loss is critical, and that is the reason we are saying, and by this technology, we may be able to at least do 60% of the liver transplant patients without even 1 unit of blood transfusion. That is what we are trying to do as far as the innovation on ground is concerned. The second thing what we said, can we create our hospitals as the safe hospitals? The hospitals of the corridors as safe hospitals, that was one digital mission which we accomplished. What we did, now this is extending to all our hospitals. We have actually done the entire hospital on a Wi-Fi, and there are every patient, post-operative and the critical patient is on biosensors. So what happened, every week there are instances, patient is in private room, relative has gone out for a coffee, patient collapsed, Biosensor picked up within 2 minutes, we were able to actually start the code blue and life saved. That is how I think innovation has to be described, that if your actions of innovations are saving somebody's life, you are able to integrate technology. I think that is where the innovation, that will be the answer for that. Similarly, there are other components. There is today radiation is a big component as far as this is concerned. We are working with a few large hospitals in the West, and this is first time they are doing outside United States, first time in India, where can we actually reduce the dose of radiation to the patients? Can we actually minimize the complication rates which are happening as far as the radiation is concerned? Can we actually reduce the exposure time? This is first time people are testing in Indian scenario, and our hospital in Ahmedabad is the one where we are doing these studies. That is where I would say the innovation is there. That is one aspect of patient delivery where we have done something in last 2 years. We are now seeing the results of this, and we will be able to come out and share more information over a period of time. The other aspects I think are very far common from the operational perspective, and I would say healthcare has been a laggard as far as the innovation and technology adoption is concerned. None of us who are sitting here can vouch that today the experience which people get in other than non-healthcare life can be replicated. Today you can buy 1 kg of tomato sitting at home any place and you can get it delivered to any person. But getting simple access to healthcare is the most difficult scenario for every person. People shudder to think that how many times they have to stand in the line. We have no respect for the people, so that people, even if they are paying 5 lakh rupees or 10 lakh rupees, people have to stand for 2 hours in the line sometime. The worst part is if you go to any non-healthcare scenario, whenever I have traveled today, Digi Yatra I think is the most fundu stuff which has happened. You travel seamlessly, but we do not have Digi Yatra kind of an equivalent story where people can walk in and they can have one registration and they can go to the reception counter and get this thing. So somewhere down the line, we are working on these aspects of saying how the journey of the patients can be simplified. Maybe next year, same time, I may be able to share more from that patient journey perspective from the digital. We at Maringo Asia Hospitals in 2 to 3 years time want to be the most digitally advanced hospital system in this country. I know I have a lot of people here who are from healthcare, but I'm simply saying out of this place because we know what we want to achieve. We know what is our roadmap, and I would be happy to come 2 years after that to say that yes, we have accomplished and we have scaled Mount Everest of this healthcare. Thank you very much.
Fantastic insights. I'm sure we all have lots of questions. We'll keep asking them. Rahul Mehra, CEO, AW India Private Limited. Rahul has worked in supply chain. He's done a great job in supply chain, especially during COVID. They have provided groundbreaking logistical solutions for supply chain in healthcare in critical times. And Rahul, what have you done? What is the future? And how can address this?
I have a lot of stories to talk about.
Oh, you can stand, please.
No, I'm okay. So I have a lot of stories to talk about, and especially innovation. Thank you, Dr. Devendra Nagar. And we have got, I believe, an impressive panelist, Dr. Rajiv Singhal. I think it was pretty much close to what we are planning and what we are doing. Our journey started during the lockdown, and this is a very, very good story. So I've got a lot of stories to talk about, and especially when we are involved with Government of India. I remember 22nd March lockdown, 25th March we were approached by Niti Aayog stating that the PPE kits, we are stuck and we need help for 2.5 crore health workers, and we wanted to reach to 736 districts in India. So India pretty huge. Till now, like I have started my career 97, I'm in supply chain. We are managing almost all the big brands, retail, fashion, Jack and Jones, Body Shop, you name it, we are managing it. But this was so exciting and so interesting because our country was managing supply chain in terms of maladi, in terms of family healthcare programs designed by UNICEF, or programs like polio drops, save life. And when PPE kits came in, they came in, imagine a PPE kit which you all know have got, when we talk about in our language, we talk about SKUs. So every PPE kit have got 6 SKUs and different size. Gloves, glasses, coverall, shoe covers. And when it started coming in from different parts of the world, so there were 2 challenges which everyone was facing. One, the setup was very small. Second, everyone wanted, and everyone wanted it as soon as possible. So how it will happen? One, somebody has to plan, allocate. So they are not working in a hospital. Like when we are working Paras Hospital, there would be someone who's planning procurement, allocation, supply chain, how much to procure, what to give. Here the challenge was countries were donating and our country was also procuring. So when you are getting donations, donations are not given to Government of India. They are given to Red Cross, they are given to WHO. So there were 110 consulates which wanted to coordinate, wanted to give something, and the aircrafts were coming and it was a total lockdown. So we started working on a system which was named Chakshu, and we gave a plug and play solution to almost Ministry of Health, Niti Aayog, and they started working on, we started defining a nomenclature of what is coming in. When is it coming? Where is it going to go? How is it going to go? And how we are going to track it, whether the beneficiaries got it or not. So this entire dashboard was created. Phase 1 was PPE kits. Phase 2 was more dramatic, which we all know, which was more to do with oxygen concentrators, oxygen cylinders. And that's how phase 2, we were pretty comfortable because we had a database. And phase 3 was a cakewalk because we have remdesivirs and tocilizumabs and all the steroids. So that is one story I remember, like we were working 24/7, everything was shut down, but it was indeed a pleasure working with everyone, especially salute to all the doctors and the entire medical fraternity who worked out, and I think those were very tough years. I came with another this was also something while we were working on the project COVID. If you must have read newspapers or news channels, Project Bhishma was launched. So our Prime Minister, respectable Prime Minister Modi, he launched a project called Arogya Maitri, 13 January 2023, where he wanted to help countries to save lives. So Project Bhishma was a part where we wanted to create 36 cubes, 2 cuboids, something like Avengers movie, where all 36 cubes have different kits and products, and these cubes and cuboids can be, I think they can be, you can supply them at any place. I think Ishan's company is also one of the probable leads, which I was talking to Ishan, that the cube can be moved from like he works with drones. So drone can be moved to any place, anytime. So this Project Bhishma, what is it all about? Whenever there is a natural calamity or a war, who are the people who are on the front line? Not the surgeons. They are the paramedic, the first aid. So if a soldier has a bullet wound, what is going to happen? Bleeding. And if you have got a lot of stuff which is lying there, he's not a doctor. He doesn't know what to apply, how to figure it out. By the time he opens boxes, cartons, he figures out which medicine, what is to be given. I think the game is over. So the chances of his survival is on speed and right medication. What have we done? We created a tech by the name Crawl. Crisis using RFID, be it anywhere, air, water, land. So this Crawl was part of a project called Bhishma, where what we did, every cube will have a specific kit, bleeding kit, forest, burning, fire, any natural calamity like earthquake in Turkey, anything goes wrong in bigger cities, super cities in India, Delhi, Mumbai, say a war which is happening in Israel. So these cubes can be shipped anywhere by air, by sea, by road, and each cube has got specific set of medicines. We just use an RFID reader without opening a box. We just scan, it shows bullet wound, kit number 22, open box number 7, without opening anything. So this is just on a phone, mobile phone, tablet. So when you go open a box, you have a kit which is already consolidated. You open that kit, anyone, a paramedic, a normal kid, an 8-year-old boy, anyone can use that tech. So this is again, which is happening as we speak. And this is going to be something which is going to transform and disrupt the entire industry the way we are doing and managing all the natural calamities. Then comes a point of language barriers. We are truly global. So we came up with very, very innovative product called WAMI. WAMI is what am I? So what am I is like any medicine. So we know paracetamol, we know Dolo, or we know anything, but medicines don't talk to us. But if we have a phone and we just go to that medicine with our camera, the way we scan a barcode or a UPI code, the medicine in your own language will tell you the composition, usage, and what this medicine is all about. So if you are sending an aid to Syria, Libya, Afghanistan, Bangladesh, anywhere, so you don't need to actually have a translator or somebody who will tell you what this medicine is. So this tech is going to transform again identification of medicines. And this is all specifically because of supply chain. We are getting closer to the beneficiaries. For social impact, there was a very, very, a request came from AIMS almost 3 months back. So AIMS has got a dispensary by the name Amrit, and they also have a free medicine distribution setup. What was the challenge? A very unique challenge which I never heard, and I never thought in supply chain that I'll ever get such an inquiry or query from a medical setup like AIMS. The setup was for a free medicine, AIMS issue a barcode or a unique number. That beneficiary goes to that free medicine shop. There can be 6 medicines, but even if one medicine is available in that shop, they will issue a token. He will wait with that token, and by the evening, 8 hours, 7 hours, or 6 hours, whatever it takes, they will give that medicine to him. And the funny part was, there are 48 counters, out of which 24 counters were only for the documentation and issuance of token. So biggest challenge, what they wanted was, a 1.5 crore of medicine is given every day. They wanted to double this amount to 3 CR. That means the number of beneficiaries or the distribution from 48 counters, at least 40 counters should be used to dispense medicine, not documentation part. And why documentation? Because they wanted to verify the genuine beneficiaries are getting the benefit of the scheme. So what we did was, any doctor which mentioned any medicine, we got our scanners in place. The scanners read whatever was there. The information went to the back end, to the medicine depot or the store behind. SKUs automatically got confirmation with the WMS or the inventory management system available, confirming out of 6, 2 medicines are available. Confirmation done. By the time a token was issued, a pick list was given to that guy who's already working on the medicine stuff. Medicines were already collected, and 40 people who were just there to facilitate the documentation, digitization, scanning, everything was automated. So this, I would say that these are the kind of things where we are trying to help, innovate, create an impact. And a lot of things we are working in terms of TPAs, because the biggest pain I talk to anyone is getting a discharge done from a hospital. You sit at 9:30 in the morning, 8, 9, and then TPA comes up with his own stories, whether consumables, not consumables. So what we are trying to create is, we created a tech called Infinity, which we are already working on. A blood group, a pre-existing diseases, a database, because we already are working on a lot of stuff which identifies your pictures, Aadhaar cards. Aadhaar we can't use officially, but there is a unique stuff which we are working on. So TPAs get an information, we get an autopilot done, it gets auto approval. So that ways, I think it is going to speed up the process, cut down on wastages, and a lot of grey system which still exist. But I'll not take much of your time now, because again, this will go on and on. But thank you, Dr. Nagar, for giving an opportunity. And thank you everyone for being such a nice listener. And we are always there if anything, any challenges which you are facing anytime. So we would be always there to support you and help you. Thank you.
I just stole time and took permission from the chair. This reminded me of my days as surgeon in Indian Army when I was posted in Siachen. And we had container operation theaters. So there were 4 containers. One was a pre-operative, one was an operation theater, one was a post-operative, and one was basically the CSSD, that kind of container. And in times of shelling, those containers could be picked up by the helicopter and could be moved from place A to place B. So I've operated in those kind of cuboids and operation theaters. So it was like interesting to hear that. Thank you.
Thank you, Dr.
Fascinating to see your journey and the innovations you've made. And I think we in hospital operations would love to get these integrations done at our level, at a micro level as well. You've talked about the national level and the bigger picture. I think we'd love to see how this can be effectively used at a micro level, i.e. hospital operations level. Atul Sharma ji, we'd love to hear from you what HMD did, how did they did. COVID तो especially एक ऐसा time था जहाँ everything was disrupted and you were needed the most. What did you do and what are you doing in the future so these things don't get repeated?
So we also had a tough time during that debate, during that period actually. We got so many calls from hospitals. Just after the declaration of first COVID vaccine, we got so many calls from hospitals, but we were booked. But the problem was that our entire production was booked for the government. And on the other side, we were getting so many calls from the hospitals, especially for the vaccination for their staff in first phase. So that was a really very tough time for us. So as first, basically we shifted our production from other syringes to AD syringes, 0.5 ml for vaccination. That was the first step we took. In second step, we convinced our customers to avoid overstocking of 0.5 ml, especially our dealers. And that was the main challenge for us. But we supplied our syringes to almost all the hospitals. We got the request from.
That was one of those one-off challenges. But what is the learning for future? कोई innovation है कि आपकी जो इतनी सारी production lines होती हैं, which are specifically meant for, one product. Now we don't know tomorrow what is the. आज आप 0.5 ml की चाहिए हमें syringe, कल पता नहीं हो सकता है कुछ और चाहिए.
Sir, एक different story
is that a process possible where we can quickly transfer one production line to the needed production line?
Sir, before commenting on that, I'll say something. It's a different story actually. जब ये कोविड का टाइम खत्म हो गया तो उसके बाद हमें कुछ कस्टमर ऐसे भी थे जिन्होंने कहा कि अभी वापस ले लो ये 0.5 ml, हमारा काम खत्म हो गया है. तो वो भी टाइम था जब हमने उनको कैसे अरेंज करके दिया था, और वो भी टाइम था कि जिन्होंने कहा कि वापस उठाओ अपना सारा बचा हुआ है हमारे पास. इवन 2 boxes 3 boxes की वापस उठाइए इनको. दैट वॉज ए चैलेंज. तो ये भी था. बट अभी अगर हम बात करें तो अभी अगर हम आज के सिनेरियो में बात करें तो एक बहुत बड़ा चैलेंज अभी है कि MRP has become a very prominent factor for purchase for the hospital, some hospitals. MRP एक ऐसा है कि जो कि सिर्फ एक अकेला एक फैक्टर हो गया आज की डेट में कुछ हॉस्पिटल्स के अंदर. सर्विसेज या प्रोडक्शन कैपेसिटी या कुछ भी क्वालिटी बहुत पीछे रह गए हैं. तो आई थिंक अगर सभी हॉस्पिटल्स पे काम करें कि हम लोग अगर MRP को देखना ही तो 2 प्रोडक्ट्स एटलीस्ट लेके चलें. क्योंकि होता क्या है एक्चुअली कि इस तरह के टाइम में, जबकि जैसे कोविड में देखा हमने, तो उस टाइम पर आपको प्रोडक्ट्स नहीं मिल पाते हैं। तो ऐसे टाइम पर फिर आप स्ट्रगल करते हैं हॉस्पिटल सभी लोग की, और जो कंपनीज होती हैं वो अपने रेगुलर कस्टमर्स को ही पहले फीड करते हैं। तो वो चीज़ अवॉइड करें, इसलिए 2 ब्रांड्स अगर लेके चलें हम हर प्रोडक्ट कैटेगरी के अंदर, तो आई थिंक दैट इज़ द बेस्ट फॉर द हॉस्पिटल।
आई कम्प्लीटली एग्री। और मेरे ख्याल से आपके लिए भी एक एमआरपी, आपने कहा, एक स्ट्रगल है। हॉस्पिटल्स भी यही स्ट्रगल फेस करते हैं, गवर्नमेंट भी यही स्ट्रगल फेस करती है। एवरीबडी इन द इकोसिस्टम है इज बाउंड बाय दीज फाइनेंशियल कंस्ट्रेंट्स। आई थिंक हम सबके लिए कोविड हैज़ बीन अ बून इन वन सेंस दैट एन एवरेज पर्सन हैज़ रियलाइज कि हेल्थ केयर की नीड क्या है, हेल्थ केयर की डिमांड क्या है, हेल्थ केयर कितना ज़रूरी है। So I believe that post-COVID situation, some of those pressures have been relieved. I am a testament to that. I can't lie that some of those pressures have been relieved. So I think I can assure you from hospital side कि आपके ऊपर भी pressures relieve होंगे। अगर नहीं हुए हैं तो रिक्वेस्ट करेंगे फ्रेटर्निटी को कि वो pressures भी relieve करें। ठीक है कि नहीं? But I think your contributions as companies and people who've helped the society at the time of need.
Yes, sir. At that time, we were the only manufacturer for AD syringes 0.5 ml. So we faced a very difficult time that time.
हाँ नहीं, वो गवर्नमेंट से सभी को डिफिकल्ट टाइम फेस करना पड़ा।
बिकॉज एक तरफ गवर्नमेंट का पेशेंट हैंडल करना कि सारा प्रोडक्शन हमें चाहिए, दूसरी तरफ प्राइवेट हॉस्पिटल्स का पेशेंट हैंडल करना कि हमें भी कुछ दो, एटलीस्ट स्टाफ की तो दो कम से कम।
नहीं, हमने तो प्रेशर ये भी फेस किया है कि ऑक्सीजन सारी गवर्नमेंट को चाहिए, प्राइवेट सेक्टर का डजंट मैटर कि क्या ऑक्सीजन मिल रही है नहीं मिल रही है। हमारे प्राइवेट सेक्टर में शायद ऑक्सीजन नहीं ज़रूरत पड़ती थी, गवर्नमेंट या हाई कोर्ट्स को यही लग रहा था कि प्राइवेट सेक्टर को ऑक्सीजन की ज़रूरत नहीं है, दे कैन सर्वाइव विदाउट ऑक्सीजन। विजय, आई वाज alluding to the fact that you are in a system which is a system for decades. How have you been able to create any innovations, and what innovations have you been able to do recently? And love to hear from you.
Good morning, and thank you so much for this opportunity. First of all, I feel very honored to be part of this August gathering. And I represent Manipal Hospital, as you have mentioned. We have 33 hospitals across the country, and we are moving towards, from a south-based NIT to a pan-India presence. So that's what Manipal is trying to do. And as you have rightly mentioned, when we have to manage 33 hospitals across the country with around 10,000 beds, so it becomes a challenge. So one thing that Manipal Hospitals as a group is trying to do is how to leverage data for informed decision making. So we have developed certain mechanisms by which especially when it comes to bringing in operational efficiency or even patient engagement or making informed decisions even at a unit level or at a corporate level, how we can use data most effectively. And another innovation that we are trying to, you have specifically asked about some of the new innovative measures. Yeah, okay. So that I would say how we can leverage technology. How we can leverage technology for better patient experience and enhancing clinical decision making or providing better patient care. So there are many examples, but I would just talk about two new innovations that Manipal Hospital is doing. One is about video consultations. So all of us know about video consultation is nothing new, and especially COVID has taught us the importance of having video consultations. But now what we are trying to do is move from a simple platform where it's just like a starting with Skype or maybe a WhatsApp video call. What now we are trying to do is to develop a platform where we have already implemented that. So where patient can, starting from appointment booking till the consultation, and this is a very seamless journey. And even during the video call, I mean the consultation, the patient, there is a two-way communication, not just about communication through a video or visual and audio communication. We're also coming up, there is a platform where which the patient who is sitting elsewhere can see the screen of the desktop of the doctor who is doing the consultation, and real-time basis, the patient can even see what the doctor is entering on the desktop, whether it is symptoms, whether it is about what kind of prescriptions the doctor is doing. So it is though we are, though the patient and the doctor is sitting at two different spaces, but it is as good as this, it's as good as face-to-face consultation, because they can even see, what information is being entered, and just by doing a screen sharing. And again, of course, communication of records and other things, and immediately, as soon as the consultation gets over, the prescription goes to the patient's mobile. So wherever they are sitting, they can see what are the tests prescribed, what are the medicines prescribed by the doctor. So this kind of a seamless experience this is our Lives On platform, where we are doing a video consultation much more effectively. Another innovation that Manipal is doing as a group is also, it's very interesting. We all know about Fitbit. We have a tie-up with Google and Fitbit platform, and this is not new, where we all know about how the data, I mean patients' parameters are collected and collated and through wearable devices. Now Fitbit has come up with an innovation that even the patient's mood, I mean what kind of, whether he is feeling happy, whether the person is anxious. So there is an algorithm by which, just by working on the heartbeat or the breathing and all those parameters, how we can even do a mood assessment of the patient. And this gives, this is a newer, very innovative technology that Fitbit is coming up with, and Manipal is already tying up with, how we can utilize this information to provide a better patient experience. So these are some of the newer technology, and leveraging technology for better patient experience and better decision making is what we are attempting to achieve. Yeah. Thank you so much.
Thank you, Vijay. I just one quick follow-up question. Okay. You said VC, you will share the screen, doctor's screen. Yeah. I mean, doctors are happy with it? Because आधे डॉक्टर कह रहे हैं मेरा टेस्ट हो रहा है या पेशेंट का टेस्ट हो रहा है? It's, I think transparency is honest.
We have an EHR, the electronic health record, and where the data is entered, basically the history, the symptoms, and prescription. And these are the, whatever that.
I think it's fantastic. We should ask our doctors also to do it.
So the patient also feels that the doctor is fully present. It's not just that there is a video screen which sees and we don't know what the doctor is doing actually, whether he is listening.
He's sleeping. No, I think it is a fantastic innovation, and I think it creates transparency for the patient. आज की डेट में तो वीडियो कंसल्टेशन में पेशेंट डजंट रियली फील इन्वॉल्व एंगेज्ड, और आई थिंक इसीलिए उस चीज़ का ड्रॉप ऑफ रेट बहुत हाई है. There's too much of a drop rate on VC. Otherwise, it was one of those innovations ki haan, it should be idiot proof. Everybody should be on video consultations, at least for the follow-up or small things. But it doesn't happen. Everybody's coming back to the hospitals. So I think with these kinds of small incremental innovations, VCs will become important in the future. On the Fitbit Google mood assessment thing, and I think we should all wear it and use Google glasses to clearly reflect mera mood kharab hai ya tera mood kharab hai. We should. But I think on a serious note, this can be a great tool for psychiatric patients, psychological assessments that are on continuous basis. We are randomly doing Q&As, and when the patient comes to the hospital, we ask them 5 questions. How was your mood? Or did you feel low? If this kind of devices are given to those kinds of patients, I think we'll have more realistic and real-time data, and we don't have to then kind of interpret when he's saying this, what does he mean? So brilliant, thank you so much. Ishan?
I would like to get some more information on that biosensor about patients. Maybe that's another university.
Absolutely, absolutely, and that's why this forum is there. Ishan, I think we are all also looking eagerly to understand from you what innovations you're bringing, and you're coming from a very tangential point of view from our side actually. हम तो healthcare delivery में इतना engaged रहते हैं, hospital operations में इतना engaged रहते हैं, we don't really look outside the box. So maybe you'll perhaps enlighten us on that.
Right, sure. Thank you, Dr. Nagar. Firstly, good morning, everyone. Happy to be a part of such a great panel. I represent Skyer Mobility. We are basically disrupting the last mile, middle mile, first mile logistics with drones. We are a SaaS-based company. I know most of you, must be thinking drones, future, is it happening, not happening? But let me tell you, I've been working on this since the past 3 years now. And we have grown a lot. We are doing live deliveries as we speak right now. I'm doing more than 50 deliveries per day, pan-India, be it in the e-commerce, quick commerce, and healthcare. But it all started with healthcare, In 2021, there was a project called Medicines from the Sky, where a lot of consortiums took part. We actually had to do a pilot where we connected the primary healthcare centers to the secondary healthcare centers in Telangana, where Niti Aayog, World Economic Forum, Government of Telangana, everyone was involved. And we did more than 100, 200 flights to show the efficacy of the system. So, our journey began from there, and then we had a lot of support from the government. They made the drone rules very liberalized, which could make us, use drones for commercial purposes. After that, we've done a lot of, TB deliveries, TB vaccines deliveries across the country. But our first use case, it started was in the hills, was in Himachal Pradesh, Uttarakhand, where the use case for drone versus road was immense. Even now, when we know that Himachal was in shatters last few months in the rainy season, we came up, we are working with the Himachal government, we have a contract with them, and we helped so many people. We delivered medicines, we delivered food, we delivered packages for just basic survival of people in Himachal. So these were the first few years of our company where we were only focusing on healthcare and trying to disrupt the healthcare industry with supply chain. And there are different aspects of supply chain in healthcare, I feel. There are internal logistics solutions within the hospital, which we have also solved for a company, actually Apollo. They were using pneumatic tubes. I'm sure you guys would be knowing about this. But we have eradicated pneumatic tubes, and we're doing inter-campus deliveries for them because pneumatic tubes are very expensive. Also, we're doing hospital to your your clinics, hospital to your labs, sample deliveries. We're working with likes of Dr. Lal and every diagnostic company in the industry, Krishna Diagnostics. So we've done I have delivered more than 40,000 samples already for one of my clients in Himachal. And to be honest, the road versus drone time saving is immense. I'll give you a few examples, a few routes. Himachal, we're doing Shimla, Chandigarh. It normally takes about 4, 5, 6 hours. Bad day, it will take 8 to 10 hours. We're doing it in 45 minutes every single day, every single time. There is no change in the time because there is no traffic currently also. We're also working with the Airport Authority of India to manage traffic. We have a platform. It's called Unmanned Traffic Management. It's called Sky UTM, where we are also managing the traffic for the drones, not only our drones, but for also the drones that will be on the system in the airspace. And now coming to the urban side, first 2 years we did a lot of rurals outside the territory, outside the states. But now from this year we have actually started Noida, Gurgaon. We've started Gurgaon, Mayapuri for a diagnostic company. Everyone over here, Noida, Gurgaon, everyone leaving Gurgaon, they know the traffic, they know how much time it takes on a general day. We're doing it in 40 minutes every single day. So we are all hooked to Blinkit, we're all hooked to Zeptos and likes of 10 minutes delivery. Name a company or name someone who is doing 10-minute medicine delivery. There's no one, right? So it's a very interesting topic because we are actually creating innovation already in the healthcare industry. Why not get medicines in 10 minutes? Why not get your samples, your reports in 10 to 15 minutes? So that's what we're trying to achieve, and that's what we're trying to solve, because I think supply chain last mile is one of the biggest problems right now, because we are all so dependent on, on a click, we need everything to be delivered at a home. So to solve that, we're also creating infrastructure in Gurgaon. We have created multiple mailboxes, which will be common for all our clients. These, the drones will go and drop the packages in the mailbox, and from there, my walker, my person would just, with an OTP authentication, take the package and deliver it to your doorstep within minutes. So yeah, basically that's what where CII is all about. We are trying to disrupt the logistics industry, and yes, healthcare industry has been very, very supportive, and we'd like to keep doing these innovations, keep solving problems, so that the healthcare industry becomes much more stronger in the future. Thank you.
Fantastic and good to hear. And I think your example of Himachal and Northeast and these hilly terrains, where access to healthcare in spite of having the infrastructure is not necessarily easy. Having a primary healthcare center doesn't mean that it'll get doctor aayega. And we've seen recently what has happened, and I think using these drone technologies will be important. Just a quick follow-up question. Let's say you're Shimla to Chandigarh. The cost of a drone operation versus, let's say, a road operation, because that's what everybody would like to understand, because otherwise it doesn't even make sense to go on the road. So what would be a typical cost to do this kind of a delivery from Shimla to Chandigarh?
Right. Very valid question. It is obviously, it all boils down to commercials in the end. So what we are doing is, so for instance, if I have a shared hub, Shimla Chandigarh is a shared hub of mine. I have a hub in Shimla, I have a hub in Chandigarh. I am not doing it for one client. I'm doing the same route for multiple clients. So I'm giving the client the same cost they would have for a Blue Dart or a truck or any car. Because I'm making revenue from multiple clients on the same routes, it's almost like aviation, It's okay. Because I am from the aviation industry, I'm trying to bring in that expertise. I used to fly 320s, I used to fly for Vistara. So all my life, I've always been in the aviation industry. So ideally, what I'm trying to do is make routes, scheduled flights, so that I also make money, and I also, give good cost to the clients, so that they can have a good comparison between the road and drone. If I give them a double or a triple cost, it won't make sense for both of us. It has to be a win-win for both the parties.
And I think that's a fantastic innovation, fantastic journey. Also, it could be a very life-saving journey.
100%.
See, not necessarily it's about cost. If I'm sitting somewhere in Shimla, I need the test doesn't happen there. And let's say biofire, I'm infection, ICU में admit हूँ. If I could just get that test done and figured out in next 2 hours, my life could be saved.
And we've done that. We've saved lives. In Himachal, we have saved a person's life where he needed a medicine very urgently, and any road transport would take 4.5 hours. We transferred it in 15 to 20 minutes.
Has the government set up this rules, regulations, protocol system for the drones, or are we still, do what you like and trying to figure out what we are doing?
No, actually the government has backed us up 100%. In 2021, they came up with the drone rules. Now we also came out with the amendment. Our Prime Minister's vision is to make India the drone hub by 2030. And he's been repeating it in all his, all his events, all his podcasts. We've been featured in one of his podcasts where we transferred apples in Kinnaur. Whereas, it takes 8 to 9 hours for a person to take it on his back. We're using drones and technology to, get the best of the apples from Kinnaur. So yeah, I think the government is really pushing it.
I think it's been a fascinating panel, and we've heard from very, very different perspectives. And I believe there'll be like hundreds of questions in your minds. I have millions of questions in my mind because these guys are so knowledgeable. Could I leave the floor open if somebody wants to ask a question? More than happy to address that. Otherwise, I'll keep asking them questions. Anyone? I can see someone want to do smiling faces, questions brewing in their head, but not, perfect.
See, more than a question, I have an observation out here, Dr. Nagar. We are having this healthcare summit, and we are just represented by the private sector and big hospitals out here, right? What about the rural healthcare? What about the government hospitals out here? Don't you think that is a part of the ecosystem? That is not being discussed at all. We are just talking about the big hospitals in metro cities and all those kind of things, leaving 80% of the population.
A very good observation. Perhaps you were not present for the opening session where we had.
No, I was there. I was like, I'm here since morning.
No, NHA was represented here. I think you observed that. That was the address by NHA, Ayushman Bharat Digital Health Scheme. That was the big takeaway from the morning session. We are talking small things. I guess we are not capable of dealing with the larger context. We are talking about small things, small innovations, small messages people can take home. I think if your idea about solving 80% of the problems is valid, but I think all of us here are only able to address very minuscule points. We're happy to engage with you, take this forward, but हमारी capability शायद कम है to address this point, but in the future we'll definitely take this up कि हमारी capability बढ़ेगी, हम government sector, public-private partnerships के बारे में ज़्यादा बात कर पाएं. But CII has addressed public-private partnerships in each of this forum, and I have seen this for last 15 years. मैं CII के behalf पे आपको assure करना चाहता हूँ कि every forum we come up, public partnership is always there, government participation is always there. हाँ, कुछ सेशंस में थोड़ा सा बायस प्राइवेट की तरफ आता है, शायद हम रिप्रेजेंट करते हैं प्राइवेट को, वो आएगा भी. यू विल हैव टू बेयर विद अस, बट आई थैंक यू फॉर योर एंगेजमेंट. एनीवन एल्स?
When the private hospital will start having Department of Health Research in?
Sorry?
When the private hospitals, usually private hospitals don't have a Department of Health Research within their hospital premises.
Health research.
Health research.
You're absolutely right. I think health research को अब digitization solve कर देगा. I think जो medical records का जो digitization हो रहा है, you don't have to be within the hospital. If we are all on EMR, if we are all on intraoperable platforms, जो डिजिटल हेल्थ मिशन मोदी जी की है, अगर हम सब उसको अपनाएं, तो रिसर्च करने के लिए आपको हॉस्पिटल में मौजूद होने की जरूरत नहीं है. आप अपने घर बैठे उस रिसर्च को कर सकते हैं. हमें डिपार्टमेंट बनाने की जरूरत नहीं है. रिसर्च कैन बी एक्चुअली एन इंडिविजुअल सिटिंग इन फ्रंट ऑफ हिज कंप्यूटर रादर देन दीज रिसर्च सेंटर्स जिनके लिए हमें एक बहुत बड़ा इंफ्रास्ट्रक्चर बनाना पड़ता है, उसकी जरूरत नहीं पड़ेगी. सो आई विल humbly suggest कि future is digital and research is individual, collaborative, but not necessarily site-based. So I feel that we should do, all of us, participate more in this. We will. Thank you so much. आपने पूछना है?
Research.
Please go.
We would want to whistle for you for both the answers, but I think to both the gentlemen, I represent a healthcare group called the CK Birla, which was the first NABH hospital of India. I come from Viji's system, Manipal Healthcare, for 5 years there. Hi Viji ma'am, I left when he joined. So they are actually the academic, the private academic medical teaching leaders, pioneers in India. We are probably the first ones in the healthcare niche sectors. All of us do at least 50 to 60 clinical audits per year in each department. even if it's 5 cases, 7 cases, all of them collate all these research papers which are presented, and none of us have their own ethical committees. Probably I don't have my ethical committee, I use this Manipal one, so there is a lot of research, health informatics being shared to government. Right now, as in we both sitting there, yesterday we signed for a software which is ABHA compliant. So being an old, 3-decade-old company, what is the government bringing it up? Private sector, why we have these forums is also to update how we have to come in line with what the government policies are, I think trying to create a framework and how do we align with them in terms of private ones. So I think these forums helps us do that, helps us create those awarenesses, and smaller examples which you people keep sharing, does enlightens us, does, networks us to good partners. We have completely outsourced our laboratory. We only have sample collection centers, even in our 100-bedded hospitals, because we have an SRL Ranbaxy just 2 kilometers away. So maybe, we would like to network with Ishan and use that money saved for something else, something better, right? So I think, sir, my message is wake up and smell the coffee. Thank you.
Absolutely. Rajiv ji, just to the end. Acha, there is, sorry. Acha, Madam Pushti. Yeah.
So hi, my name is Shikha. I'm part of the CK Birla group. I think whatever we have said in relation to technology, I'm a hardcore operations person from aviation background. I was part of Air Sahara and Kingfisher Airlines, and then eventually joined healthcare business. I still feel we lack a lot in terms of technology. Comparing it with aviation, I think 80% of the task is driven through technology. There is very less human intervention because obviously there are 0 chances of error. Whereas I feel in healthcare, when we are dealing with direct lives, wherein the work is totally dependent on saving anybody's life, we lack a lot on technology. The best example I could state here is the discharge process, which is a pain process in every hospital, and the OPD wait time, wherein the doctor eventually spends 30 minutes with one patient just to inform the patient about the surgery and pre-op and post-op care, whereas there is another patient, who ends up waiting outside for 2 hours for just one consult to get over. My submission here to the forum would be, why don't we collaborate together, and think of a solution or a software which would help save patients' time. You would see a lot of feedbacks for every hospital on social media platform about the wait time, discharge process, patient experience. Vis-a-vis, if you go to any aviation or a airline Google reviews, you would just get to see only the positive impact. Yeah, so just a submission here that we should all collaborate and think of a better software, and I think every hospital should use the same software. Like in aviation, there is Sabre, one software which is used by multiple airline chains, right? And not even a single complaint on the technology. Yeah, thank you.
I take your point. I think we need to do a lot. Technology needs to be involved a lot more. And we have to kind of come out of that mindset that technology is a cost. It's not a cost. It is an enabler. And I think starting from myself, I have changed that mindset. Even my mindset, और थोड़े से doctors biased तो होते ही हैं, even my mindset has changed. Technology today, I don't look at it as a cost. I look at it as क्या कर सकता है मरीज के लिए, qualitatively, efficiency wise, और hospitals के लिए भी. And I think government is also doing the same. उनको भी realize हो रहा है कि भैया technology के बगैर हमारा काम भी नहीं चलेगा. We won't be able to get to the last man. And I think all of us together can share knowledge, share information, learn from each other, and everybody on this dais, but most importantly, each one of you who carries some knowledge with them should share with at any platform possible. My doors are always open. Our doors are obviously always open to share, interact, learn. I think we've taken enough your time. मुझे बहुत सारे सवाल पूछने थे. I would have loved to ask you many, many more questions, which I will do offline. Thank you so much for being such a brilliant audience, listening to us. There are few key takeaways. I'm sure privately आप और भी टेक अवेज ले जा सकते हैं. Thank you so much for your time. Pleasure.
I would now like to request Dr. Dhaminder Nagar to kindly present a token of appreciation to our panelists today. Dr. Rajiv Singhal, Managing Director and Group CEO, Marengo Asia Hospitals. Mr. Rahul Mehra, CEO, AWL India Private Limited. Ms. Viji Varghese, Hospital Director, Manipal Hospitals, Dwarka. Mr. Atul Sharma, Senior Manager Sales, Hindustan Syringes and Medical Devices Limited. Captain Ishan Khullar, AVP Business Development, Sky Air Mobility. I would now like to request everyone to join us for tea, coffee outside. We reconvene in 10 minutes for our next discussions. Thank you. Our next discussion, which is a presentation on prioritizing air quality in healthcare facilities by Mr. Deepak Nanavare, Head Marketing and Business Process, AAF International, EEMEA, CIS and SARC. Request Mr. Nanavare to please come on the dais. I would also like to invite Mr. Gaurav Agarwal, Principal, Public Health, South Asia, IQVIA.
They are bringing people in. Sorry? They are still bringing people in. I suggest you both maybe give a brief introduction of yourselves or take the stage to yourselves. Enjoy it and we'll have people in, then we can start the presentation. Thank you.
I now request Mr. Agarwal to please take the proceedings forward. Thank you.
Thank you, CII, for giving us this opportunity. I'm Gaurav. I'm a principal at IQVIA. IQVIA is a health technology and advisory firm, a unique firm which kind of works both with the private sector and the public sector. So we've been working across 100 countries with the private providers and payers, and at the same time with a lot of government agencies and development partners like the World Bank, ADB, USAID, on various public health strengthening and those services. We've been, at a unique position, as I said, given the fact that various unique challenges of both hospital operations, providing quality healthcare services to the population in general. We've been, associated with private providers and pharma companies to, one, improve their operations, improve access to medicine either through technology or various other supply chain management and procurement options. And at the same time, working with the government and development partners to kind of enable them bringing health system strengthening changes, right from strengthening a primary healthcare center in a remote part of the country
towards defining universal health coverage like PMJ for the country. With me is Mr. Deepak. I would like him to introduce himself as well as his company and the topic. Thank you.
Yeah, thanks, Gaurav. So, good afternoon all. I hope all are back, charged with a small amount of snacks and tea. So, I am Deepak Nanavre. I am heading the marketing and business process for AF International for the India, SAARC as well as Middle East and Africa region. So, basically I am a HVAC professional with 17 years of experience into designing and handling various applications from the airports to oil and gas to commercial buildings, and in the recent assignments mostly associated with the clean rooms as well as the IAQ. So clean rooms like the part of the pharma manufacturing where it's supporting the healthcare by delivering the right quality product, contaminant free. Similarly, into the microelectronics where you want the technology to work flawlessly. And then handling on the IAQ part with the rising in the air pollutions, with the rising in the infections, then the pandemic, as well as the different scenarios in different applications. So where we use our expertise to deliver the tailor-made solutions, working on the guidelines from the global standards, associations, and the continuous research from our end to how to serve the humanity better.
In case we have a full audience, Mr. Deepak, I request you if you could take the audience through your presentation, and then we can have a brief conversation after that.
Sure. So I will be using the DAS. Thank you. So I hope all are back, full house. So I would like to thank you, my colleague Mr. Shailesh, who started the day in the inaugural pointing out on the indoor air quality, which is started in the news, and maybe in the coming 2-3 months it will be a boiling topic in the NCR region. Apart from that, I will be thanking the panel members who were there, who were talking about the technologies, the AI and the Internet of Things using in the healthcare. So technology is evolving, and we are changing from one system to another system, and accordingly the products are developed. Similarly, the building structures are also changed. So from say 2-story, 4-story buildings, now we are having all the buildings into high rises, specifically even the hospitals tall into a beautiful glass facade, and very less openings on the front because it's the aesthetic view which is most important in terms of the view. But this also adds to the problem because it will be limiting the designer on the part of adding the pressure or designing the right system for the air conditioning airflow required inside the facility. So when we talk about the buildings, so there is a terminology called sick building syndrome. So it's not only the patients or the humans can be sick, the buildings can even be sick. So when you talk about the sick building syndrome, there are 3 important pollutants which affects the building inside comfort. The first one is biological, which most of you are aware because into healthcare sector, the viruses, bacteria. The second one is the chemicals which are generated inside during the daily operations by the disinfectants, by the detergents, by the cleaning, or maybe by the carpets, or multiple things are there. Apart from that, the particles which are maybe coming from the outside and mainly from the human body, the dead skin cells and other parts. So these all together, if you are not removed properly, will be converting your building into a sick building. So this sick building further fuels down to increase the risk for hospital-acquired infections with respect to healthcare facilities. So in hospital-acquired infections, you are giving a breeding ground to the virus and bacteria to stay in the air for longer time, to free freely and to infect the other patients and specifically the healthcare workers who are present over there most of the time. So the target or the agenda is to how we can avoid this and how we can ensure the safety for the patients as well as the healthcare workers. So majority of the sick building syndrome, which is also fueling the hospital acquired infections, that will be having the airborne pathogens, which will be silent killers, as well as cross contamination, the fungal growths and other, the ventilation which is not moving. So on this, there are already guidelines available across the globe. One of them, the prominent one, is from the NHA, which is the governing body for the air conditioning engineers. So in that, these are the some areas which are mostly present in healthcare facilities, and these are the base guidelines that you should be using minimum these levels or the 2 stages of filtrations to protect the environment, to protect the occupants inside the facility. Apart from that, based on the pollutants, there can be different set of filters can be used. The other slide is again from the NHA, is about what should be the ambient or what should be thermal comfort inside. So in a general term, when we see thermal comfort, it's only the temperature, whether I am feeling chilled or hot. But it's not only about the temperature, even the humidity, which impacts the growth or the life of the bacteria and the growth of the mold and spores. Apart from that, the outdoor air, which is required to maintain the oxygen levels. We all know the price of oxygen after the pandemic. So we need more and more fresh air to be present inside the facility, so you get the natural oxygen. Apart from this, when I shown in the previous slide, having the 2 stages of filters. So filters cannot work independently. They need air to be moved along or against them, so that the air changes per hour. That means how many times your air is getting circulated inside the facility, inside the room. So more you have the air changes, faster will be the cleaning. So for example, if you say 20 air changes per hour, so you are cleaning the air every 5 minutes inside your facility. So we are representing AF, which is 100+ year old company, present in 150+ countries, supported by 33+ factories. And in India, we have presence in Bangalore as well as Noida, headquartered or founded in Louisville, Kentucky, and currently owned by Daikin, Japan. Apart from that, we have state-of-the-art research centers where we do test live bacteria and viruses in our US facility as well as Japan facility. And we continuously work upon increasing the filter efficiencies, the filter lives, the filter technologies. And the team is supported by 7,500+ people globally. So over to you, Mr. Gaurav.
Thank you, Deepak ji. In fact, quite insightful given the fact that we take clean air for granted when, as a patient, while visiting a relative or a friend into a hospital, assuming that the air would be clean. So this brings me to a question. While you've laid down the regulations, guidelines, and everything, but if you look at a typical hospital, a multi-speciality, super speciality, I'm assuming the ICUs, the OTs are where probably the air would be the cleanest, right? But let's say on an overall basis, can you kind of identify or let the audience know about areas where somebody won't expect that level? I mean, somebody may just be expecting that level of clean air, but actually it may not be. So, I mean, is it possible to kind of have some insights into that a typical facility, these are highly contaminated areas that we kind of don't realize just through naked eye? Thank you.
Okay. Sure, it was a very good question. Because I think so in the inaugural, Mr. Shailesh again said about the critical areas. Specifically, the OTs or the ICUs and ICUs has stringent guidelines. People are aware because our healthcare, the doctors will be cutting open the patients, and there is a very high risk of getting infections. So such facilities are already protected in most of the places with the HEPA. There are basic guidelines from NABH for India, but except the critical area, the non-critical areas where you have a very higher footfall. For example, the OPD, where you have your registration desk, where you have the patients coming in, where sometimes you have the basic pathology facilities available, and then you have a consulting rooms where the doctors are sitting and working around the clock to cover up the patients. Like I was listening, there are doctors handling 300, 400, 500 patients. So you understand the risk he will be having when consulting with these so many patients. And this is the first interaction where you don't know what is the infection he is carrying. So apart from the surgery level or the physical level infections, the airborne infections are very easy to spread and contagious.
Thank you. Thank you for that. So while you have kind of laid down shown everybody the solutions that you have, the products that you have, I'm assuming most of the hospital chains will be following the national guidelines and having their own, filtration systems installed. So specifically talking about your solutions, what is the kind of delta it has in terms of on the OPEX or CAPEX of a typical hospital? And is there an opportunity for retrofit, or virtually at the greenfield stage, the solution can be designed, accounted for, and implemented? So I just want to understand the kind of impact it has on the overall costing of a typical healthcare facility. Thank you.
Okay, yeah, that's what the crux of the previous panel discussions about the cost, or as Dr. Nagar said, technology is not a cost. So when you are designing the facility, it's very easy to implement, and I appreciate the efforts even the government as well as the private hospitals are putting to have the more energy efficient buildings and going for the LEED or WELL certifications, where they know the importance of the energy, as well as there are pretty much good guidelines placed in the LEED and WELL certifications to use minimum stages of filtration, which I showed in the previous chart. But apart from that, if you, as you said, if you are going for a retrofit, so if you have a centralized air conditioning system, there is not a cost difference because you already have the certain stages of filtration. You have to just upgrade to the next level. If you are not having the centralized air conditioning system, or if you are using the room air conditioners and all, so there you can go for the portable air purifiers, but not the residential one, because they are not meant for the critical facilities where you can go for a air purifier with a dedicated HEPA, not in a 25 mm you have 6 stages.
Thank you. And I'm assuming the benefits go beyond, or let's say the delta goes beyond the financial implications. I mean, you're giving your patients much cleaner air. Even the people who just walk in, they kind of don't carry the hospital-acquired infections if you have those kind of filter systems in place. This brings me to my last question. And while you as a product company, let's say you must be dealing with mostly the decision makers on the design side or the finance side, how much of end of the day, it's the hospital staff which has to, work in this particular environment. Whether the filter is there or not there, they are the ones who are kind of have the initial liability to be infected. So how much of the onus is on, let's say, a healthcare service provider or an equipment manufacturer like yourself to make all the hospital staff, right from, let's say, a cleaner to a CMO, aware of the requirements of this, make them kind of, have better practices in terms of ensuring that none of their activities are contributing to any sort of pollution, not just air, but let's say other part of it. So some sort of training, capacity building, awareness, how much of that is important, which probably in a way, in the short to medium term, lead to hospitals adopting such more clean practices? Thank you.
Okay. So the use of air filtration, I will say it's not a luxury, it's a necessity. Everybody has a water purifier at home. Nobody drinks the tap water now, neither in the rural also. Everybody has the water jars. So why don't we have the filters? Because we can't see the air. We should have the HEPA filters. So apart from the patients, like who are visiting, the healthcare workers who are there day in, day out, they will be protected. They will be protected from the infections. So their absenteeism will be less. There will not be any cross-contamination, or maybe the virus mutations because of these cross-contaminations. And if you remember, during the COVID time, if somebody has to do the surgery on the COVID patient, he has to be isolated again for the 14 days. So if you have these type of filters installed, not only in the OT, but in the other areas also, where you have the presence, where you see the infections can occur. So in such cases, we should be using these filters. And apart from infections, if you see there are multiple reports, like as I said, it will be the hot topic in NCR. The people in the NCR already have lost 10 years of their life because of the air quality. So after knowing this, why you want to take the chance, and why don't you just implement the filtration levels on the slightly higher side? And believe me, the cost of the filters is far, far lesser than the cost involved for the absenteeism of the manpower, the health effect they will be getting, their fitness levels, their, say, work comfort. Because normally we give these calculations to the IT companies where the humans are the assets. So they have research studies done based on the user comforts, their productivity, and other parameters.
Thank you. So the much loved HR division of healthcare facilities becomes a potential client for you too. Great. Thank you, Deepak ji, for this, and look forward to the next session of CII. Thank you.
Yeah, thank you so much, Gaurav.
Panel discussion shortly. Just allow us a few minutes to have the dais set up. The next session is on reinventing healthcare with technology, which we'll be just starting. I would now like to start with our next panel discussion, Reinventing Healthcare with Technology. I request Dr. Upasana Arora, Co-Chairperson, CII Northern Region Committee on Healthcare and Director, Yashoda Super Speciality Hospitals. Mr. Abrarali Dalal, CEO and Director, Sayadri Hospitals. Ms. Seema Vij, Facility Director, Paras Health, Gurugram. Ms. Khushbu Agarwal, Founder, Zyla Health. Mr. Namit Chugh, Principal, W Health Ventures. And Dr. Rajiv Gautam, Corporate Officer, Horiba Limited, Japan, and President, Horiba, India. I would now like to request Dr. Upasana to please carry forward the discussions. Thank you.
I think after tea, everybody must be feeling fresh. Otherwise, I have to sing a song, Jagore, Jagore, Jagore. I think everybody is already Jago, Jago. So, from the morning, we are talking about digital health and new technology, innovation. So, and this session totally based on that how healthcare is adopting new technology and new innovation. Every hospital is doing something different from each other because there is again a competition between everybody that meri sari inki sari se safed kaise. So mera hospital, how is better than others. So trying to prove ourselves, whosoever are doing digital innovation, they are the beneficiary because when somebody is talking something new, like in today's morning session, someone was talking about that Asia Moringo Hospital. I thought I should talk to him because if they are doing something very nice and different from others. So this session, all my panelists are actually doing something different from each other, as well as there are one person who is totally dedicated to technology. So before we start, I think I should tell you who is my panelist. Mr. Rajiv Gautam, who is a corporate officer, Horiba Limited, Japan. Basically, this company is devoted to laboratory for hematology, and we are also using their instrument. He is going to tell us about how technology is helping in pathology sector. So he will talk about that. Now we have Namit Chugh, who is a principal W Health Ventures. He is the one who is investing in others' innovations and doing boost to startups. Now we have a Khushbu Agrawal, who is a founder, Jaila Health. I met her before also, and I am proud of her because she is very young and she's, started something new and she's a dynamic leader. Now we have with us Mr. Abrali Dalal, who is the CEO and Director, Sahyadri Hospital. And Sahyadri Hospital is doing very well in Pune. I think you are Maharashtra. So Maharashtra is having very good hospital, but still I should really recommend their name because it's a big chain. Now we have Seema Chugh. Seema Vig is with us, who is working with Paras. And it's hard to accept for me such a beautiful and, very delicate lady can look after all the big hospital, everything regarding hospital. So I think it's high time everybody can say that females can do everything. So with these words, I think I should start from the first person who is sitting there. So Namit, you please tell how you are investing in, and what is your criteria when you select a person that you are going to invest with them?
Well, thanks for having me, Dr. Upasna, and thanks for the esteemed crowd here today. So when we are investing in any particular startup or a venture, there are a couple of things that we look out for. Team that we are backing is obviously the first one. But I'll not go into the details of the team, but more talk about venture, what it is building, what is the technology behind it, and so on and so forth. So let's just maybe take a step back. What is it that India is struggling with today? Yesterday was Mental Health Day, and there are only 9,000 psychiatrists in the country, only 1,000 therapists in the country today. And it's even hard to put a number to the number of people who are suffering from depression, anxiety, and a whole host of mental health issues. So we can't add doctors overnight. It's a noble cause. So technology is the only solution that can kind of address your demand-supply mismatch that exists across several specialties. Again, I was reading somewhere 1 in 10 Indians in their lifetime will get cancer. 1 in 15 Indians will die of cancer. So broadly, 150 million odd people will have cancer in their life. And how many oncologists do we have? 2,000. 800 medical oncologists, and then rest between surgical and radiation. So we need to, as an investor, our endeavor is to back companies which are using technology to change the way how care is delivered. Think about augmenting doctor capacity. Obviously, a clinician cannot be replaced from healthcare. So at the core of all our investments, we have a clinician who is trying to address some of these problem statements, trying to give access to cities where we don't have access today. And second part is patients need a lot of time. They need a lot of hand-holding, companionship, health coaching, so on and so forth. Do we have the time as doctors or practitioners to give a couple of hours to each of our patients? The answer is no. Look at the disease burden in India. So how can technology address some of those things? So those are the core principles that we look at when we are investing into a company. Apart from that, obviously, patient retention, patient trust, clinical outcomes, so on and so forth are some other parameters. Financial performance of the venture, how scalable the problem statement is. I think those are some standard investing metrics. But as I said, can't emphasize more on the importance of technology. Dr. Nagar in the last panel was saying technology is not a cost, it's an enabler. I think we also strongly believe in the same. How can we leverage what exists and how can we use technology to augment it? Having said that, very quickly, the last point I would like to make is the use cases of artificial intelligence. It seems like a buzzword right now, but we've probably seen 200 companies in the last 6 to 8 weeks which are building for AI use cases in healthcare. Either building from India for the rest of the world, where the adoption is going to be much faster. This could be around insurance, claims management, prior authorization, note-taking, a lot of things which can improve the clinician productivity, save their time. And then there are a whole host of things in AI which can actually help clinicians make better decisions. So the clinician AI, in my opinion, is going to take some time, a couple of years, till the data becomes robust enough. But the administrative AI, the low implementation AI is going to scale very, very fast. So healthcare is going to be one of the sectors which will get impacted in the next 2 to 3 years in the positive direction because of artificial intelligence. So that's one more space that we kind of keep a very, very close eye on. But yeah, to summarize, backing companies which are building at the cusp of care delivery, innovation, and technology. So that's my
Thank you.
slightly
Thank
long
you so
answer.
much, Namit. Now, I think we should make something very, different. I don't want to go to Khushbu now. Now, I would like to talk to you, Seema. What Paras Hospital is doing new in terms of technology to create more, flexibility for the patients?
Thank you very much, Dr. Upasna, and thank you CII for bringing this, adding a knowledgeable day in our calendar. So, ma'am, coming back to your question, what are we adding in our hospital to ensure that the patient should get something new through the technology? I would like to say something that we have talked much about the video consultation. We have talked much about EMR, but I think the technology is needed right now for our patient, which starts from their home. So if I talk about 7 to 8 years back, we were very, very, casual calling up for the appointments. Right now, we are so used to of using Myntra and mobile apps where we do not want to call anybody and we want to fix up everything on our phone because that's one thing which is very, very handy. So while picking up the appointment system from that particular time when the patient is home, booking up the ambulance, if in case anything needed, Paras Hospital already had an app having an emergency call bell where you just need to press a call, emergency call button and we will be ready with the ambulance at your home. So this is one of the things I think we are looking out, to provide us to our patient from the day time. And then once you, come up to the hospital, I think one of the very big pain which I'm experiencing and seeing with my patient, that it's very difficult to park the vehicle even in the hospital since there are thousands of people coming every day visiting to the hospital and then there are no parking. So you can book the parking also while coming to the hospital. And, then coming in, your bill is, you can make the payment online. You don't have to wait being in the queue. Just straight away go to the consultation room, see your doctor. We are absolutely becoming now paperless. You don't need to carry any of your document. Everything will be on your mobile. So, every time whenever we used to go to the hospital, we have to first search for all the documents. 6 महीने पहले मेरा X-ray हुआ था. साल भर पहले मेरा mammography हुआ था. I have to carry out all my reports and then go to the hospital. So one of the things I think the evolution we want to carry forward to our patient is you don't need to get anything. Even you don't have to come and ask me for any of the bill. Everything is there on your app. After the consultation, the prescription also is there on the mobile. You don't have to call, you don't have to ask the doctor, okay, give me my prescription. Then when we talk about prescription, there have been, might be, the test investigations given by the doctor, the medication advised by the doctor. You don't have to even be in the line paying for the investigation or paying for your pharmacy bill. Just say that you want it. Press the button and all the bills will be there. You can make payment through your credit card, through that particular app, and you'll be done. You can book the home sample collection, So we are trying to make every step coming to the hospital, assuring this that you don't have to struggle now while you are, stepping in our hospital. This is one of the aspects which I will talk about, which I have, given you the insight for the OPD. And when we talk about the patient who needs admission, we are right here to launch our EMR in IPD also. So even when you are coming after your admission, the consultations, everything, any critical report, the doctor will bang on, get the information that yes, the patient admitted, my patient admitted in my hospital has got raised or maybe having a HB lower. So all pinpointers getting, so that the treatment will not take much of the time to be delivered to the patient. Whether the doctor is out of the hospital at the middle of the night, we are right there with the technology to ensure that my doctor, my nurses, everyone engaged for that particular patient should get the information.
Thank you, Seema. It's really very nice to hear that it's so easy. Patient journey has to be easy. That is how patient feel, that somebody who is caring for her or him. So, and I would like to tell that this conference is little bit different because every day I am doing some conference, but I must appreciate my secretariat that they have chosen the right speakers here, because I have heard so many speakers from the morning. Everybody is doing something different, which is not very much, in the industry right now. So it's high time that we should actually switch over to this digital health and everything. So now I think I should talk to Khushbu. Khushbu, you please tell us about Xyla, how you started, what was the motivational factor behind this that you have started this?
Sure, thank you so much, ma'am. Thank you, CII. Thank you to this amazing audience here today for listening to us and innovating with us. So I happen to be a healthcare enthusiast. I'm extremely passionate about healthcare. I live, breathe, eat healthcare. I'm a pharmacist, MBA by training. So to the point on inspiration, ma'am, I basically was a healthcare consultant with Deloitte and Monitor. I was in the US for larger part of my career back then in California. Now what triggered the thought of Xyla was my own sort of personal event while I was building with large insurance companies, large pharma companies, the biggest strategies globally with Deloitte. My own father, who's been a diabetic for a couple of decades, he happened to have a sudden heart attack, and I got a call one evening from my mother that, dad's in the hospital, and your world changes when you hear something like that. Given I'm from healthcare, my family is a hypochondriac. This was a sudden shock, and I'm sure all of you have had some sort of this shock in your near and dear families. So that's when I started questioning the purpose of my existence and also the purpose of healthcare. I flew back in that very night, the toughest 24 hours flight I ever had. We saved his life, thankfully he's under Xyla care. But what I want to tell you is that the purpose of healthcare really is outcomes, is to keep a patient healthy. And while today, we have the largest and the best of hospitals, we've heard from Paras, CK Birla to Yashoda, and the greatest infrastructure, the largest, best of doctors, medical tourism, medicines delivering in 10 minutes, the best of UPI and technologies that the government is driving. Still, people are dying at a very young age of complications of a chronic disease, right? So in India, a patient has a heart attack at an average age of 50 years, 50. In the US today, the average age of a heart attack is, guess, 69 years. We are literally 2 decades behind in terms of healthcare outcome. So to all the great visionaries and people running great institutions of healthcare, I want to appeal to you. The purpose of healthcare was healthcare outcome. So that was my calling. I started Xyla back in 2017. Extremely moved by the mission of helping a chronic patient improve their outcomes, preventing the next hospitalization. I termed it Xyla because I wanted it to be a confidant, a friend, yet a medical expert who stays with you and guides you through this very complicated journey of a chronic disease. Now I want to talk to you about how we're enabling this and what I want to, my dream for the country. My dream for the country is that a patient walking out of any hospital, of a diagnostic lab, of a pharmacy, of any healthcare infrastructure is put on a continuity of care that they need at that very point, right? So we created a continuity of care ecosystem which records the history of the patient in medically coded language, which can integrate with any hospital, any insurance company, right? Also aligns with Ayushman Bharat digital mission. We created care pathways which will enable the patient to get the right advice on their medical and lifestyle needs. And then we created a 24/7 system to stay in touch with the patient, because unless I know what symptom is happening, what is the progress on the symptoms reported, what is the latest biomarker, what is the health issue, I'm not able to create an impact. So we created technologies which were very organic in need, right? We started with pen and paper and PDFs and Excel sheets. But then we realized that I hired an in-house care team, right, of doctors, nutritionists, physiotherapists. We realized that even though I have the best of brains, right, they're still missing out on protocol. They're still missing out on data points, right? A patient is reporting leg pain. It could be diabetic neuropathy, or it could be an electrolyte imbalance, or it could just be myalgia, right? Who will catch these insights from the data points and compare it with Xyla protocol, which is based on the international guidelines? So we created Athena, which basically is an anomaly detection engine, which will keep comparing the longitudinal data points of a patient with the latest input from the patient and highlight to the care team that this may be off, this requires intervention, this requires questioning, this requires a doctor consultation. We created Leah, which is a chatbot with a human escalation layer, which stays in touch with the patient 24/7. India runs on WhatsApp, so we thought, what better to guide a patient than a WhatsApp like 24/7 care system on the Xyla app. And we created another technology, Iris, which will personalize a nutrition plan, exercise plan, basis your hundreds of parameters, medical symptoms, history, as well as whether you're a vegetarian, non-vegetarian, whether you like Bengali food, Bihari food, what is your weight, and so on. So these three technologies enable the highest quality of care for 1 lakh patients on a monthly basis today. And what I'm proud to tell you is that we have not forgotten the ecosystem, right? It's not some parallel ecosystem which is running digitally. I want to integrate Xyla with every hospital, with every lab, with every pharmacy, with every insurance partner to create an ecosystem of care, and with Ayushman Bharat, right? So we've created an API-led integration ecosystem. We integrate with all national labs. If my patient needs a diagnostic test, someone will reach their home and they'll have the most seamless experience because I've integrated via APIs with a 1mg, Redcliffe, Apollo, Metropolis, and so on. We have in the roadmap to integrate with hospitals so that any patient walking out of the hospital gets post-operative care very, very seamlessly. And our main clients are insurance companies, right? Because for insurance companies, we take care of their high-risk lives, right? So that their claim of these high-risk life reduces. I return an ROI to this insurance company while the patient improves their health within the insurance premium that they have paid, right? I don't want to increase the cost of the end patient. So we integrate with insurance companies very, very deeply in that regard. So I'm very excited to be working with the hospital ecosystem in the midterm. And I think my dream for Xyla, where a patient has 85 years of average life, very little complications, and a healthy quality of life, even with a chronic disease, is not far away. Thank you.
Thank you, Khushbu. So as you can see that today's conference is actually introducing many new different kind of innovation as well as very beneficial things like this air quality, drone. And I was really, I don't know how many people are going to get benefit from this conference, but I am the biggest beneficiary from this because I am going to call everyone because I need them. So now I am going to talk about your hospital and your basically experience. Abrari, please बताएं, what is your take about technology and how you are using technology in your hospital?
So thank you so much, and thank you CII for having me here. See, I believe that, and it's a fact that healthcare is an extremely manpower intensive, effort. And day in and day out, your nurses, doctors, paramedics, and your GDAs, ward boys are working to ensure that the patient gets a good clinical outcome, good service delivery, and that's healthcare. It is extremely, it's a big human effort. And it is always, everyone in the hospital is always trying to manage the life cycle of the patient. So technology has to be integrated in a manner in which this staff of yours, which takes care of the patients, is benefited, is happy, becomes more productive, and becomes more efficient. And that is going to directly impact patient care. A happy employee, a happy team is going to give you a happy patient. If your employees are stressed out, not looked after, they cannot deliver that patient service delivery that we all desire. Now, if you look at my organization, we are 1,300 beds. We're the largest hospital chain in Maharashtra, including Mumbai. We have 8 hospitals, we have a lab business, we have a clinical research center, we run a nursing training school. So taking care of this human effort becomes very important for us to kind of deliver that service and that, what do I say, that image that we want. 2 years back, we embarked on a mission to create a hospital management software. Which we launched this December. So in fact, this December we complete the rollout, and we try to integrate all these points where the human effort to take care of the patient is leveraged or is supported by technology. So I'll give you simple illustrations. There are many illustrations that we have run with HMIS, but simple things. One is like fixing an OPD appointment in a hospital. It's not so easy. You first call the call center and then the hospital pay a message advertising their latest heart transplant. The patient is listening to it, then eventually your call will land up to some call center agent who will probably not be well trained enough to answer your queries. So it's an experience which takes time and it's not very accurate. You may not be able to choose the doctor you're looking for, or you may not get information about the doctor that you want to see. So we are working on an AI chatbot on the app. You just go to the OPD page and you select the doctor you want, and the chatbot is going to help you answer questions about the doctor. Kitni surgery ki, what is his resume, and any questions you may have, because now the public is Google savvy and they've already Googled the doctor, and they've figured out and they have already made an impression about the doctor. So the AI chatbot that we're working on kind of increases or betters your OPD experience. That's one thing that we are trying to implement in the software. Then once you're in the OPD and EMR is fine, everyone uses EMR, but after the consult, the patient will go for a PATH test, or recommend a PATH test, a pharmacy test, diagnostics. So we have tried to kind of get diagnostics at the click of a button. Usually you wait for reports, MRI reports, or CT scans. It's available on the phone. You get your reports, and you can also get a telemedicine or a virtual consult with the doctor to figure out the reports. Normally the cycle is very vicious. The patient will go, he will go to the diagnostics, get them done, then come back with the report, wait in the queue. So that's the second thing we've implemented in our new software. Again, something that is supporting not only the people in the OPD, but also giving some sort of ease to the patient to access those reports. The admission process, again, is a QR coded process. You can actually go to the app and you can fill in the details. So the patient who's getting admitted can just fill in his details, and a QR code is generated. When he comes to the hospital the next day, he has to simply show the QR code at the front office, and he'll be taken into his respective room, single room, double room, etc., and get admitted. Otherwise, the admission process is very tedious. The patient would land in, come to the hospital, and someone would explain to him. This is obviously, I'm talking post-counseling, would take him to a room. So it cuts short all this. So that's what we're trying to do. We are trying to make the basic technology which helps the human effort. Now again, nurses, if you look at the nurses or the outsourced manpower which is in the hospital, they're running everywhere and they're highly inefficient. A nurse spends probably more time doing paperwork sometimes than attending to the patients, because they have to do the paperwork, they have to indent medicines, they have to fill reports, they have to sign something. So we've gone online on that. We've tried to create tablets which makes life easier for the nurses to indent and deliver that patient care which is necessary, so on and so forth. I think I really believe that we in all these forums talk a lot about innovative technology in healthcare, and we are basically talking of the icing on the cake. Even if, I heard the sessions in the morning, and these are very visionary thoughts that were discussed. But I really think that the basic cake needs to be in place first before you ice it. And I think we should talk more on the base than on so much innovation that is really very dependent on the base, which is honestly not there. So, even today after running 8 or 9 hospitals, I know that basic technology needs to be put in place, and that basic technology has to help the human effort and the patient delivery process. I think that is very important, and that is missing. And even the Arogya scheme that was spoken about in the morning, and getting access to digital records centrally across the country is very difficult, because I know that even in my 8 hospitals, if one patient goes from A hospital to B hospital, it is very difficult for him or the doctor to access his records, let alone doing it nationwide. So I really think that let's make our base strong, and let's use technology to make the basics of healthcare very strong, which will help the human effort to deliver patient care. Thank you.
Thank you so much. And I think you really touched the point, because whatsoever is happening, new technology and all, but patient is always looking for the touch of a doctor, as well as he want his journey in a hospital very smooth. So we should work on that. And now actually technology is doing so well, so we can take help from them. Now it's your turn, Rajiv ji. Please tell us how technology is now changing your pathology sector, and how Horiba is, trying to adopt all the new technology.
Yeah. Thanks, Upasana ji. I think I am from the other side, rest of the hospitals. Here I am from the lab side. I will give you a simple example that in this country there is 1 lakh laboratories, more than 1 lakh laboratories. 50% of the laboratory are in the township and villages or something, and there is no pathologist. There are only technicians, and the instruments are there, maybe simple instruments are there, but nobody is ready to report the key situations. So what we have now, we are using the artificial intelligence, and we have instruments which can be given there, and you can make the slides in hematology, make the slides and just transfer it to the main lab in Delhi, Mumbai, somewhere else, and then pathologist read it, report it, and the report goes via WhatsApp or email or something. That's a simple use of a digital morphology which we are using, but it is intelligence, and there is a library into that. It's a huge library into this instrument, so there is a base. That's how simply I think Apollo is using, and the many hospitals have started using for that situations, because they cannot appoint pathologists everywhere. It's not that. So many pathologists are not, histopathologists are not available. So that's why, that's a simple but very, very effective use. We are using, along with all hematology analyzers, we are using these technologies, AI technologies, and it's getting popular day by day. It's only hematology today, then it can be other things and other things. So many things can be done. Just pull the samples, report it, and everything is there and it goes to the doctor. So that's just one example, simple example, so everybody to understand that what can be done for them. Thank you.
Thank you, Rajiv ji. I don't want to end this session right now, because I think there are many questions in everybody's mind. So before I open this hall for questions, I think we should, one more question I have from you. So Namit, please tell me, just what do you think about new startups? Do you think that from different field people has adopted technology, and if they were even engineer, still they want to become a techno savvy, and they are doing some startup in that? Because you are meeting very new and young boys these days. Please tell me about them.
No, I think I am always passionate about startups, given that I am a venture capitalist, and all I'm looking out, the way Khushbu eats healthcare for breakfast and lunch, I eat startups for breakfast and lunch. See, for any sector to be disrupted, generally people who are outside of the sector come and make that dent. Between all the founders that we have backed so far, people have worked in consumer tech startups, FMCG companies, airline companies, whole host of different experiences. They're coming together and trying to understand healthcare, getting help from hospitals like yourself, getting help from clinicians, and trying to build something which hasn't been disrupted. And these are areas or spaces which are, I would say, new age specialities. Obviously, hospitals have built, or hospitals are built for saving people from dying, because that's the business model. But how do you make sure people live a healthy life, right? That's where some of these startups come into picture. The way Khushbu explained, right? Capturing data, being a 24/7 companion, and so on and so forth. So the hospital business, and 97% healthcare in India is still offline, so hospitals are not going to go anywhere. These startups are just going to come and augment some of the use cases that are probably not high priority. innovate in new disease areas where we haven't seen too much disruption happening, and use technology, come with a new lens, come with a completely different state of mind or frame of mind to make some of these changes. And I think both, and healthcare is going to be phygital in the next 5 to 7 years. It's pure digital, I don't think, in my opinion, does not work because clinician still needs to see the patient at the end of the day. So, and that doctor trust can be established only when they touch and feel the patient and so on and so forth. So, but yeah, very, very excited, continue to back startups and happy to chat with any startups that we might have here apart from Khushbu, of course.
Thank you. Now, Khushbu, what is the driving force behind this new generation who are from different, if they were working something else, but now they want to do something in technology. What is the driving force behind this? Can you please explain?
So, ma'am, I've seen usually it's personal experiences that drive these things, because building a company is really, really hard. You have to solve literally 100 problems every day, you know. You have to get to the solutioning, hire the right team, raise funds to build the technology that you envisage. You have to find customers who will pay you. You have to scale it up and, you know, remain persistent in that journey, not give up. And I always tell my team, being a leader is the hardest, because how much ever tough your day has been or whatever your personal life is going through, you always have to have the smile and the passion in front of your team, in front of your customers. So I would say that personal drive is very, very critical. And that's what I've seen working. I have a lot of founder friends. I'm a part of a lot of female founder groups. So I've seen that people who thrive and stay on for years, it's been 6 years for me, I still feel it's the starting of the journey, are people with a personal mission.
Thank you, Khushbu. So now, Seema, can you tell me, like today we heard from NHA person that he said ABDM is now very good and we should apply. So do you think private hospitals can easily go for Ayushman Bharat and ABDM?
Ma'am, truly I believe it's very, very difficult right now for a private sector, since there is a lot of cost involved when we talk about the services providing to the patient. When a patient comes to a hospital, they also have a lot of expectation that in private sector, if I have to come, I don't want to wait time. I don't want to wait in the lobby. I have to see my doctor immediately, since I'm paying that much of amount. And I should be taken up for, in 15 minutes if I need an admission, 15 minutes I need to go to the room. There are a lot of things, we have to take care while talking about the expectations of patient while coming to a private sector. In Ayushman Bharat, I'm not denying that the government is helping the poor people, and we are all there. We have the ECHS, EGHS panel patient who are coming every day to us, and we are helping out with the same kind of services like we are giving it to the cash patient. But yes, it's still a way forward. We need to look whether we will be able to adapt that facility or not.
Thank you, because you are quite right that it's not an easy task. We need to put lots of effort, and ABDM, actually I really wish to adopt that technology, because it will be very beneficial for everyone, even for the doctor, for the patient. But same time, how to implement, it's a question mark. But now, Mr. Abrari, can you just think about ABDM in your hospital, because you are having 8 hospitals, if we can apply this, and what benefit you think you can get from that?
Okay, so I think it's very different here. We actually do the Ayushman Bharat. I have a hospital dedicated to Ayushman Bharat. I have a linear accelerator dedicated to Ayushman Bharat. So we do it in a hospital in Pune, one hospital which is 50 bedded, and we channelize all our Ayushman Bharat patients, or it's called the MJPJY in Maharashtra, Mahatma Jyotiba Phule Yojana. We get them to that hospital and we treat them. And it's not been difficult for us. I think it's, if I look at the profitability, it's a pretty decent profitable business. I think the money comes quickly from the government. We also have a hospital dedicated in Nasik. So our Nasik hospital reserves the floor for Ayushman Bharat. And we do it rampantly. We do it in a city called Karad as well. And we've had a very good experience with Ayushman Bharat in every manner. The government is cooperative. Obviously you have to liaison with them, which we do. But I think it's something that we should go for. But yes, if you're talking of the Ayushman Bharat digital mission, where you're saying that get all the records in one place, I think that is very difficult. Even when I spoke earlier, I said that we are still building our basic cake of technology, and ABDM is the icing. So until the basic is not in place, you cannot do the icing. I really refuse to believe that even at 10 or 12 or 15 hospitals set up, if data exchange or patient record exchange is so easy for the doctor to go and see in any hospital. For example, a patient came to him, and he can see his records in a hospital where he's been treated. I think it's not so easy to do, and I think we still need to get to that stage. That's what I think about ABDM.
Thank you so much. Rajiv ji, what do you think? What is the future of telepathology? Like teleradiology is already existing and it's very much in. But what do you think about telepathology, which is not that much common right now?
It will be and it should be. Without that, I think we can't handle the load. I just give you one example other than what I gave you for the digital morphology. Sample collection from a far places is a very difficult. You may still have a lab, but the problem is that sample get wasted in 4 hours or 5 hours. So now labs are using the drones. Okay, so that's the one more step ahead. So they are bringing with drones the samples, and then report is being done. Maybe tomorrow, some other situation, some other material, maybe spare parts for keeping the machines. I think the drone can be very, very useful in the far reaches places. One is that digital situation, the digital pathology, what you are talking about, radio, whatever it is, telepathology or whatever it is. I think future is there, but still there is a lot, scope is there, and still people are doing it, but it's a long way to go to me.
Thank you. And I think this is the time to end this session. But same time, I must thank you, CII, for organizing this wonderful session. And everybody is not talking about digitization of healthcare. And we are actually doing, but when this time will come when everybody will use technology in healthcare like UPI, which is very easy, and like people like us, like me, who is not very much tech savvy, but still like I am using UPI. So I think this time will come, and in our next conference, we are going to talk more about different things, and we will implement all those which we talked about today. So thank you so much. Now I think it's high time to go for lunch, because when lunch is waiting, so nobody wants to wait here and to listen anybody's lecture. So thank you so much, CII, and thank you so much everyone who is present here.
I would now like to request Dr. Upasana Arora to kindly present a token of appreciation to our panelists. Mr. Abrarali Daral, CEO and Director, Sayadri Hospitals. We have our next session right now. After that, we have our lunch. So I request everyone to kindly be seated. We will just start the next session right away after this. Are you sure? Yes. Ms. Seema Vij, Facility Director, Paras Health. Ms. Khushbu Agarwal, Founder, Zyla Health. Mr. Namit Chugh, Principal, W Health Ventures. Dr. Rajiv Gautam, Corporate Officer, Horiba Limited, Japan, President, Horiba, India.
I am sorry. I thought it's 2 o'clock, so it's time for lunch. But she told us that you have to sit here and attend next session. So kindly.
Allow us 2-3 minutes for the changeover. Post that, we shall begin our next panel discussion on building resilient health infrastructure, challenges and solutions. Starting with the next panel discussion, building resilient health infrastructure, challenges and solution. May I request on stage Mr. Nilesh Maheshwari, Senior Principal and Head Public Health, South Asia, IQVIA. Mr. Sunil Khurana, CEO and Managing Director, BPL Medical Technologies Private Limited. Dr. D.K. Gupta, CMD, Felix Hospital. Mr. Tarun Tripathi, Business Unit Head, Quidel Ortho. Dr. Sachin Gupte, Lead State Operations, PATH. And Mr. Ravideep Singh, Associate Director, Creative Designer Architects. I would like to request Mr. Maheshwari to please proceed with the
Thanks.
further. Thank you.
Thanks everyone for the patience between our session and the lunch. We would want to be very engaging. First of all, I would like to thanks the CII for organizing this session. It's a very important one, as what we have realized is post the pandemic, both the government, industry, private sector, regulators, and all stakeholders have realized that we will need to really strengthen our healthcare systems. And a big part of that would be the healthcare infrastructure, new medical devices, training our workforce for optimally using these systems. And while we do that, specifically with respect to our healthcare systems, I think one of the important part and endeavor would be to keep the climate change in focus. Climate change is one of the most worrying factor for humanity nowadays, with estimation of about more than 10 to 12 million people dying from it every year. What is even more important to understand is that healthcare sector itself is one of the largest contributor when it comes to global gas emissions. It contributes about 5% of those emissions. If it were a country, it would be about the 5th largest country post US, Russia, China, and India when it comes to global net emissions. So thus it is very, very important to understand that while we build the infrastructure, while we bring in new medical devices, while we strengthen our workforce, how we are keeping at least the climate change and the impact that it would have on public health in our thoughts. We have a very esteemed panel, and I'd like to thank everyone to join this session. I'll just quickly introduce all of them. We have Mr. Sunil Khurana, CEO and Managing Director from BPL Medical Technologies Limited. We have Dr. D.K. Gupta, CMD from Felix Hospitals. We have Mr. Tarun Tripathi, Business Unit Head from Quidel Ortho. We have Dr. Sachin Gupte, Lead State Operations at PATH. And we have Mr. Ravideep Singh, Associate Director, Creative Design Architects. So without much ado, I'll start with Dr. D.K. Gupta, you. I think one is in terms of, from a private sector perspective, when you're looking at, one is creating new infrastructure, optimizing the current infrastructure for the training of the workforce and others. How do you look at building it more resilient from a perspective of any future pandemics? Thoughts from you in terms of overall how the private sector provider is looking at it and how your hospital has taken some innovations would be really good to understand.
Thank you, Nilesh, and thank you, CII, for organizing such a wonderful event. And I think all of we realize that post-COVID, our healthcare infrastructure should be resilient. It should be strong enough to deal such pandemic or such epidemic in future. I think we have at least everyone has experienced that there was a lack of shortage of manpower, hospital beds, ventilators, ICU beds during pandemic, and definitely we were not doing enough in the healthcare sector. If we talk about health sector, we are investing around 2.5% of our total GDP. That is lowest among developing countries, not even developed countries we are talking about. Even WHO said it should be 5%. Developed countries average invest around 10 to 15% of their GDP. Even the Italy, who was investing more than 15%, they were poorly handling the COVID pandemic at that moment of time. So I think there is a huge scope. And one thing more, there is one more paradox. 70% of the healthcare infra is confined to tier 1 cities only. However, our Indian population, that is actual Bharat, that is residing 70% in the tier 2 and tier 3, even rural remote areas of our country. Means where we require actual healthcare infra, that is area, the rural India, where we are lacking right now, and it is mostly confined to these tier 1 cities. And there is one more paradox, that 70% of healthcare delivery, either through beds, nursing staff, doctors, OPD, indoor patient admissions, that is happening provided through only private players. It is fully dominated by private players. Only 70% of the 30% of the services are provided by right now by the government of India. It means private healthcare providers, private healthcare partners should be empowered, should be strengthened, should be be a partner in government initiatives to at least provide accessible and affordable healthcare services to remotest of the country, remotest area of the country. And for that, definitely we need lots of things. I think if we should start from hospital point of view, for hospital we need two major things, capex and opex. If we talk about the capex, definitely we need building. And right now, I think everybody, whosoever is from hospital industry, they will feel that we purchase land at commercial rates. There is an auction of land everywhere. All the authorities across India, they auction land at commercial land, and the government and the public expect to give subsidies from us, to take subsidies from us. So land should be subsidized, it should be allotted at a reasonable rates, at a prime locations. And if we talk about the building part, definitely buildings should be resilient, they should be earthquake resistant, they should be like LEED certified, green buildings should be there, highly ventilated, natural light should be there, and definitely it should be energy optimized also. Like energy buildings should be designed in such a way that energy operational efficiency should be increased. So that's the second part. Financing and funding. We all know that this is a huge heavy asset model, and for that we definitely need subsidies from government in form of easy financing, in form of rate of interest, lower rate of interest. Currently, all the banks, they are providing rates at the commercial rates. There is no subsidy from the government of India or finance ministry or any private or any nationalized bank that there is a subsidy for healthcare providers. So I think there should be some subsidy for the making a hospital project. And if we talk about the plant and machinery, hospital equipment, they are all very costly. Mostly they are imported, and we have lots of heavy import duties, heavy GST on this. I think government should think on this. If they want that we should open hospitals in tier 2 and tier 3 cities, definitely I think government has to work on these things. If we talk about manpower, in hospital we need specific or specialized or skilled manpower to each and every specialty, even each and every function, those are carried out inside the hospital. For that, government has started so many initiatives, like they have opened several new nursing colleges, they are developing district hospitals to medical college, but still there is a quality consciousness is there. I think there should be quality manpower that should come out from these nursing colleges, hospitals, or medical colleges, or skilled paramedical institutes. One thing more, specialists and super specialist doctors, they are not enough for tier 1 and tier 2 city right now. In even Delhi and NCR, we are struggling for super specialist doctors like gastrologists, gastroenterologists, cardiologists, etc. I think we have to increased number of specialists and super specialist seats across medical colleges, across the bigger tertiary care hospitals. DNB seats should be increased so that number of specialist doctors and super specialist doctors should be increased to provide healthcare services to remote or tier 2 or tier 3 cities. If we talk about the IT systems, that is one of the most important, I think, point. Already it has been discussed in the previous panel. IT infra should be very strong. It should be digitalized. Everything should be patient-friendly, patient-centric, and there should be ABDHM. We were talking in the last. There should be ABDHM implementation in all the hospitals, despite so many problems, despite so many difficulties, because it will create a atmosphere, ecosystem of inter and interoperability. Like it will empower doctor, it will empower patient, it will empower healthcare providers, it will help in proper diagnosis, maintaining the records, help in treatment, and it will help in diagnosis and reducing the complications. So I think these all major points should be keep in mind to, I think, make our healthcare infra more resilient, more strong. Thank you so much.
Thank you, Dr. Gupta. And I think you raised a very important point in terms of that. It is imperative for the government to work closely with the private sector. It still delivers about and takes owners of about 70% of all the medical services being provided in the country. And it's important to have the support system in place to be able to build resilient infra, especially focusing towards specialty courses, PG courses, to have trained workforce, and also providing at some sort of support in terms of clean and green facilities. I'll come to you, Mr. Sunil, from a perspective of medical devices industry. It is still in the nascent stage when it comes to local manufacturing within the country, a focus on local manufacturing, and it's still a long way to go. What kind of support systems do you see that may come in from government, from a regulatory perspective, from a subsidiary or larger support perspective, which will probably propel this industry to, one, have much more focus towards local manufacturing, second, have a larger access to the population at large, and third, in terms of how then this industry can look forward to grow and serving the needs of the population.
Thank you, Dr. Nagar and CII, to have me here. I am part of this medical devices for nearly over 4 decades now. And I definitely want to say here that in this 4 decades, the way I have seen, it's very encouraging what we are seeing in last 5-7 years. 5-7 years, there are a lot of policies which are very positive. But before that, let me just set where we are. We as a Indian medical devices, size is only about $12 billion. The global size is about $550 billion. If you look at China, most of the time we are being compared with China because similar population, about 1.4 billion, very similar population. They are about $105 billion. So it's a huge opportunity we have to grow. There is a lot of space, but we have to also understand why we are not growing. I mean, in my view, you have to have money to spend. I mean, every individual has to have a money to spend. Where are we on a per capita? We are still per capita about $2,000. With the population, we become about 3 trillion economy. But as this per capita income goes, you will see more and more people going to hospital, and they would need more and more equipment. So that's the basic science. 92, I remember first MR was installed here in the private in Delhi, and that was Dr. Mahajan's MR. And I was with him at that time. He decided I will put a 5,000 rupees as a rate. At that time, in about 32 years back, 5,000 was set for a MRI procedure. Today it's about 8 to 10,000. But if you look at the earnings, probably have gone tremendously different. A lot of feeling is there that we are very expensive, but let me tell you, we are lowest today when it comes to the patient charges, lowest. You look around, I mean, you get about $15, $18, you get a CT scan done. Nowhere in the world it is done that way. So I feel that as paying capacity goes up, as insurance goes up, you will see a growth happening. That's one piece of it. Also, just look at the data points. In 1950, the average age of India was only 32 years. Today, we are talking of 70 years. And are we really prepared to look at the aging population, which is more than 10 crore today? And by 2030, it is expected to reach more than 20 crore. I mean, that's the way data are coming. Are we prepared to supply connected home care products at home? Because you just can't keep building the infrastructure. You have to figure out how can we have a lean infrastructure and still manage it. And that is where probably at home, and that is also a lot of, it's a pending with the government, that at home care can we create a small setup where one nurse can come and your insurance supports it. So that's another area which, can actually ease out. This is something, which is going to ease out. Universal health care, we all expect that, we need to have. Primary health care, government is trying to do a lot. But ultimately, when it comes to the policies, government has launched a new policy by name, Production Link Incentive. And this is working pretty well for the medical devices. A lot of companies, including us, have got that license. And certain percentage of the total size of revenue we get back as a... Similarly, production is one. But one major issue which has been in India is a technology. Medical equipment technologies were not done much here because partnership between academia and industry was very little. If you see, we acquired a company in UK. It was a fully owned company by BPL Medical by name Penlon. Penlon came from Oxford University. Professors at engineering and medical side put together, created that company. And it is very, very important that you have a partnership, which is not really very high here. So those are the challenges which I see. One more area is a PRIP. PRIP is something which is, this is a R&D subsidy which has been launched about 3 weeks back by Government of India, because you need to have a more and more R&D, and that R&D will then feed to the local products. And these are the things which are happening. I am very optimistic that this industry is going to grow big, and probably we will see about 20%, 18 to 20% CAGR. And I feel that by 40, we should touch 100 billion, which is what China is today. Thank you.
Thank you. Thank you, Sunil, for bringing forward the importance of the medical devices industry and how we need to have a more future-proofing systems in place, wherein we look at home-based care, usage of medical devices which can provide care to people directly in their homes. I think an important aspect would also be, and which I would want Tarun to take forward on the medical devices itself, from a perspective of innovative technologies and how some of the innovations are happening in this area, keeping the climate change, environmental friendliness in place, and some of the innovations which are being brought forwards by your company as well.
Thank you, Nilesh. So basically the topic was building resilient health infrastructure. So I mean, as a company, we have been focusing on not only providing the instrument and reagents, but also on building the capability of the lab people, because it's not the training just for our instrument, but we are also looking at training how you maintain quality and all other aspect related to lab. So we, in addition to what we do it for our instrument, we also build capabilities in the laboratory to improve upon many things. So this has always been our focus, and we have been quite successful in it. And during COVID, we realized that some of these people who are trained by us, they were able to take up, building the PCR laboratories, and in a very short span of time, because the time was the essence, and they were able to do that. So I think that is one thing which we bring in. The other thing was what Dr. Nagar was saying, that we don't require so many pathologists. So we have something called as middleware, which can help, take care of maybe 60–70% of regular tests. So you just, the software takes care of those 60–70% of the test, and the pathologist or the biochemist, he focuses on the 20–30% which are more critical. So he's not, sort of ticking all of them. So the 70% can be auto-verified. So I think that that's something which we are, trying to build, and we are collaborating with the hospitals and the laboratories to build a very robust sort of software, so that, we don't miss out on anything. The other thing which we as a company have done is we are using waterless technology for biochemistry, and considering that water is a scarce resource, and especially in India, the quality of water is a challenge. So, you require a lab grade water to be used in an instrument. So, for making 1 liter of water, you require maybe 10 liter of raw water, and 9 liter is wasted. So, we are using waterless technology where we don't require water. So, that way we are helping the hospitals to, in terms of the environment sustainability initiatives. So, I think that's one of the things which we are doing. So, and what COVID has done is it has brought IVD diagnostics in the forefront. Earlier, people were thinking that, okay, test, karna hai, nahi karna hai. That was the thing. But after COVID, now everyone knows what antigen is, what antibody is, what PCR is, and what CT numbers are. So I think that has really helped the IVD industry to grow, and it will help the clinicians to diagnose, with evidence. So I think that's what we have been doing it. So yeah, that's all from my side.
Great. This is very interesting, Tarun, in terms of how an event really changes the perception of the population, and also in terms of how some of the technologies are being taking care of the fact that what impact climate change has, and how some of those can be taken care of while developing these kind of devices. What I'll do is I will now go to you, Dr. Sachin. Being a healthcare practitioner and working back with government stakeholders, multilaterals, technical agencies like WHO, UNICEF and others, and international NGOs, how do you see governments supporting some of the drive on bringing resilient healthcare infrastructure, its focus towards adapting to the climate change needs, and the support that it can provide to the private sector, specifically when building infrastructure, supporting from our medical devices, advancement in the medical device perspective, and the training of the workforce, which is a key area for everybody?
Okay, let me first dissect your question. It's a long one. Anyway, thanks, Nilesh, and thanks for the opportunity and having me here, Nagarji. So your email has really worked. I'm here. Well, I find myself a little bit out of the place because I see since the morning it's all about industry and the private sector, but I'm so happy to be representing a different industry, which is not for profit, and I'm a career public health person. I'm a trained doctor, a medical doctor with MBBS and a master's in community medicine, but of course I did my master's also in public health from NHA, and for the last 25 to 30 years I've been only working with the government, with the bilateral agencies and the not-for-profit. So I think what I can bring on the table is a perspective that is completely different than the private sector work that you're talking about. And it has been a great education for me since morning because I could get everybody's perspective, of course, and that's wonderful to have the other side of the fulcrum as well, to know what's happening. But more importantly, since the topic is health resilience, it is also important to know that we are not just talking about private sector health resilience here, and we really need to look at what's happening on the public side as well. As we all know that India resides, 70% of them is an agrarian economy and is a rural economy as well. And it's very important to lay the context of what the government is doing. To your question, Nilesh, and it's my duty to lay that context. Primarily, and I'm not going to go down to the cliched conversation of COVID-19 and pandemic, everybody do relates to that, but it also, I feel that it took a lot away from us, but it taught us a lot as well. When whatever we are right now, we have taken our lessons and experiences from COVID. And I want to use that as well. And the government, to their credit, has taken a lot of learning from that experience. And those who are not working very closely with the government, let me tell you that it actually highlighted the whole issue of investments in health and healthcare expenditures for the public health goods for the community and increasing those percentages against the GDP of the country, right? And just to let you know that the National Health Policy, which came in 2017, there was this very, very ambitious thought of putting or increasing the healthcare expenditures as against the GDP from as low as 1.15% to 2.5% by 2025. And I must tell you that over this period of time, from that onwards till 2023, we have made significant progress on that. Actually, as I speak, I mean, we had it at 1.9 in 21, we had 2.2 in 22, and in 23 it is 2.1. So percentage-wise, we have gone up. But it is also important for everybody here in this room to know what the government steps have been. Immediately as the pandemic struck, the government was seized with the fact that we certainly need much boosting in the healthcare infrastructure across the country. And it's about nation building. It's not just about private and public, right? So I'm going to touch base on a couple of policies that the government came up with. There is something called as PM Abhim, which is Pradhan Mantri Ayushman Bharat Infrastructure building, okay? PM Abhim is management. So what it does is that there is an outlay of 64 lakh rupees, basically 64 lakh crores if I'm correct. And there is another outlay called 15 Finance Commission, which is obviously looked for a larger development. And in that kind of an allocation, we have 70,000 crore rupees out there. And the primary intention of the funds are to increase the block level healthcare infrastructure, which I don't know how many of you here from the private sector have ever gone to the village and seen what a sub-center looks like, or a primary healthcare center looks like, or a block care looks like. I mean, these are the structures that we are catering to the population much beyond. 70% of India lies there. So the government's intention was to enhance the infrastructure, which includes physical infrastructure, human resource. I'm not going to use the word manpower because it is gender insensitive, and I'm going to use the word human resources here. Sorry for that. But that's what they were looking at, increasing the diagnostic capacities, setting up integrated laboratory infrastructure at the district. Then you have the critical care units and also enhancing the infrastructure at the district hospital. And this has been happening for the last 2-3 years. And my organization has been working very closely with the government in almost 10 to 15 states, helping and providing the technical assistance to the government to raise that up. We talked about another policy of the government, which is about the digitization. We talked about ABDM, but I understand the flavor of the room is that most of the people think that it is very tough. It is very tough. It is very challenging, given the whole ecology of the healthcare system in India. But then eradicating polio and smallpox was also very tough. We begin now. Maybe we reach after 10 years somewhere close to where our success point or where our goal post was. I would love to tell the private sector practitioners here, do not lose your heart. It is going to be a tough road. It is going to be a tough journey. We have to walk that together. The intentions are good. And if that happens, you are going to provide the necessary power to the people, and also it helps the private practitioners and the government sector as well. And we are also helping the government do that. There is a policy from NHA where they are actually piloting 800 urban areas. They call it as 100 microsite. And our organization, through middle level NGOs, are engaging with private practitioners in slums of Mumbai, in urban areas of UP and multiple states actually. So just letting you know that while the bigger centers are, of course, a part of the focus, but also, the small private practitioners with 1 or 2 seats are also on the target, and they are being reached out to. So that's one of the areas that I would love everybody to look at. But as I say this, what I was mentioning to you are nothing but the 6 building blocks of health systems. I might just want to reiterate for everybody, the building blocks for health systems are health services, emergency medical drug availability, your data management, governance, health financing, and basically, all the systems covering the logistics and supply chains. So this 5 to 6 areas, if you take care, you're actually looking at a holistic level of health system strengthening. While the government is doing everything and anything that they can in their own capacity, given the expanse of the country, is this enough? Clearly not. We are way too short of where we need to, and that is where I feel that we as partners towards the health building and the nation building of the private and the public sector need to come at together. And let's say people like us or an NGO, then there are philanthropic organizations like Bill and Melinda Gates Foundation. I mean, my friend Devendra was here in the morning on the dais, and the NHA joint director was there too. I mean, we work very closely with them. We have other organizations like USAIDs, the Rockefeller Foundations, the ADB banks, the Welcome Trust. They're all seized with all these areas of work that we are talking about. And Nilesh did mention about climate change. I was wondering that this word did not come up since the morning. And believe me, the next 5 years, the biggest challenge for human mankind and the race here is, if at all we are not prepared to manage the vagaries of climate change, we are heading for a much bigger catastrophic disaster for human race, much, much bigger and larger than what we saw as COVID, okay? And I'll tell you something on that. Climate change, everybody has seen the rain patterns are changed, there is global warming, greenhouse effect, everybody is knowing about that. But it has direct implication on health, food security, water, sanitation, availability of potable water, financial loss, and it is going to have a disproportionate impact on women and girls. So I want to just flag this for everybody. And the hospitals here or the private sector, you can do a lot while the government is doing a lot. I just want to touch base on certain things that the government is doing. A couple of years back, they actually started multiple missions. As we speak, I think there are 8 missions which are directly under the government, and they have set up purely to address climate change. And climate change is not just a health sector issue, it's a multi-sectoral issue, okay? So it's water, sanitation, energy, fuels, health sector, everything. And when it comes to health, I just want to let you know that when we work for oxygen in COVID, we made sure that we work with foundation like Celco, that can we have a solar power grid where we can have less carbon footprint just to run an oxygen plant. Similarly, in a hospital, if you want to run a hospital, can we just convert completely from a fossil fuel-based electricity to a solar-based electricity, or something like an alternative energy levels that you can look at? Somebody was talking about the logistics and how we reach across, but my way of looking at things is that even the logistics supplied to the hospital, be it vaccines or your drugs or equipment, they do come from a road vehicle or any kind of other equipment that are used. We need to look at if we can change those equipments to an electric equipment or something which is environmentally friendly, because at the end of the day, you're still living carbon footprints, and here is going to be the major area of concern going forward. So that's one area that I would leave you with a thought on. And another example is you can have a deep freezer or ice-lined refrigerator for storage of vaccine, which could be run on green energy. Okay, that is another area that we can look at. Multiple kinds of approaches can be done on this, and as I speak, many organizations are seized with these issues. And the government of India has also come up with state-level climate health change policies purely for health. And the state governments have worked on it and created a framework and an architecture on how exactly that can be taken forward. So anyway, I don't think I needed to steal people's thunder here, but I felt that I needed to put this perspective on the table, because it's not just about private sector, it's private, public, both together. And it is not the prerogative to have an efficient healthcare system and health longevity only with the state or the central government. I think it is a societal commitment. I'll stop here.
Thanks, Dr. Sachin, for those insightful examples. And I think clearly reinforces that both the government and the private sector need to come together, and there are partners in the ecosystem along the way who will be able to bring all of them together and navigate this space as we move towards building this resilience. I'll come to you, Pravideep. From a perspective of building the resilient infrastructure, your experience from architectural perspective becomes very important, looking at physical, social, environmental resilience when it comes to building new infrastructure. How do you see that change coming in? What are some of the innovations that are happening in that area which can be taken up by the private sector when they're thinking about building new infrastructure in place?
Thank you, Nilesh, and thank you, CII, for having me. So from an architect's perspective, I run an architecture company that specializes in designing hospitals. And from my perspective and from a facility design standpoint, I look at resilience in 3 different areas. And resilience, to be honest, has gained a lot of prevalence after the pandemic. And it primarily happened when hospitals across the world got incapacitated during the pandemic in terms of their inability to expand the number of beds or respond appropriately to that unexpected influx. So the 3 areas would be, I would say, digital resilience. So everything that has to do with technology. I think technology was extensively spoken about and discussed in the morning. But I mean, if you look at the statistics, there are about 11 million health apps registered as of today. The health app industry has grown from 2 billion in 2017 to about 102 billion in 2023. So while there is a lot of activity happening, but we look at the ground level metrics, about 60% of hospitals in the US and about 30% in India are on apps. However, if we look at the active number of users, it is less than 1.5%. So while a change has begun, I think there is a lot of time when the technology integration in facility design and operation will take time. So as an architect, I would suggest what are the integrations that technology and physical infrastructure can look at. One is primarily the integration of digital interfaces, wherein there is more digital interaction with the patients to streamline their patient experience and the healing journey. A lot of outpatient queuing, queue management, booking of consultation is already happening. So I think that is the tip of the iceberg to get this initiated. Secondly, I would look at environmental or ecological resilience, which is essentially, I would say, pandemics or extreme environmental events. Now, that is probably 1 in a century occurrence. However, there are a lot of lessons that we have learned, wherein when we are designing a new facility, we should not compromise against the codes and compliances and the bylaws. Resilience or surging capacity is something that most of, I would say, global bylaws have already incorporated, but they were perhaps unfortunately not referred to or incorporated. So whenever we design a facility, there should be ideal space, there should be a predefined thought or a scenario in terms of surging capacity, in terms of triaging and segregation. So what this entails from a facility design standpoint is planning a proper emergency department that is able to screen and seclude patients right at the entrance. Now, screening and secluding patients, what it essentially means is physically isolating the spaces as well as mechanically isolating the air conditioning systems. Now, if this is not done during the design phase, it is very difficult to implement during the operation of a hospital. The second component of resilience in terms of influx talks about surging capacity. Now, surging capacity is not as simple as the ability of a hospital to add a number of beds. It also talks about additional infrastructure and spaces for staff, medical paraphernalia, and so on. So there is, in fact, a guideline that American Nursing Association talks about, which says it has to focus on 4 S's, that is staff, stuff, structure, and systems, which in detail talks about what are the, I would say, not only from a facility design standpoint, but from an operational standpoint, compliances, and thoughts that have to be given in terms of operation to factor for unprecedented surges. And the third area of resilience, in my opinion, is the social and the political resilience. So after pandemic, I think behavioral health is getting more destigmatized. I mean, statistics suggest about 1 in 8 people in India has some degree of mental health disorder. So when we are designing facilities, I would talk about a normal patient who walks in. he is under a lot of stress from anxiety of treatment, invasion of privacy, separation from loved ones, anxiety of medical bills, and so on. So how a facility can help alleviate that stress to some extent, I think adds significantly in terms of how his patient journey transpires. So that is one area which I think now a lot of facility providers are beginning to acknowledge and implement, and which doesn't necessarily entail a lot of cost. It is more of thought in terms of integration of natural light, use of warm, conducive colors that have a heal impact on the patient. And the fourth aspect, which is probably the political aspect, I mean, we are amidst a very volatile healthcare space right now. Every day there's a new cap on medical treatments about how much patients are allowed to pay and so on. Towards one end of the spectrum, the cost of building a healthcare infrastructure is increasing, and towards the other end of the spectrum, the out-of-pocket expenses of the patient and the healthcare earnings are decreasing. So this is an area precisely wherein architects, facility designers, and providers need to work together, how we can design facilities that are more modular, that are cost efficient. The time to get a facility up and running is quicker. So I would say a 300-bedded hospital would ideally take about 20 to 24 months from conception to inception. So how we can compress the construction timeline. We are looking at brownfield projects wherein you identify an infrastructure amidst urban areas that is defunct, not operational. We use that infrastructure that helps save a lot of embodied energy, also helps to save a lot of cost and time. So we are able to get a hospital up and running in a matter of 10 to 12 months. This helps significantly in terms of both environmental as well as financial benefits to the healthcare institutions. So I think these are a few areas that we are working on these days.
Thanks, Ravi. This has been very, very interesting in terms of how some of these solutions that you have said can really build resilience for a long-term perspective, and how both the government and the private sector can look at it in terms of when conceptualizing new buildings or refurbishing the current ones. This has been a very engaging, very insightful and discussion. I understand that we are really late for the lunch. So if in case the audience have any questions, the panel would be happy to take. If you have a couple of questions maybe.
I think it's been fascinating to listen to all of you guys from different perspectives, starting from public perspective, public sector perspective, right to the design and development part of it. Sachin, you mentioned that the government was coming out with a scheme of, I didn't get the acronym, infrastructure mission, 70,000 crores or whatever that.
Yeah, that is actually for beefing up the public healthcare infrastructure, which is called PM Abhim, the Pradhan Mantri Ayushman Bharat Infrastructure Mission. That is PM Abhim. And that's meant for basically sub-centers, block PHCs, critical care units, district hospitals. That's the layout for a select geography.
So I think some of us at least have seen these primary healthcare centers and secondary healthcare centers. They were built 30, 40, 50 years ago. And they have enough land. Why doesn't the government monetize that land and build brand new infrastructure, and it doesn't have to pay zero?
Yeah. So
primary healthcare center में आज की date में 100 acres is required to build an AIMS. I don't think so.
No.
They could build an AIMS in 5 acres and rest of the money can be used for actual operations. India's problem in public sector is not the infrastructure. It is the utilization of infrastructure. It is the operational part of it. हमारे यहाँ हार्डवेयर पे बहुत पैसा खर्च करने में सबको मजा आता है, सॉफ्टवेयर में जाके सबको प्रॉब्लम हो जाती है. एंड हेल्थ केयर में सॉफ्टवेयर एक ही है, ह्यूमन रिसोर्सेज, मैन पावर नहीं, आई यूज द वर्ड ह्यूमन रिसोर्सेज. That is the key to developing Indian healthcare. So I completely buy that argument, except that we can pivot and leverage. Yeah. And I think all of you have touched from different perspectives, and all of these solutions are valid, and we all need to adopt over the next decade all of these solutions. Thank you.
Thanks.
Thanks. Adi? Just one question which I had from a regulatory perspective for the medical devices industry, and maybe Sunil, if you can elaborate on that. How do you see some of the regulations government is currently having? What could be the support from a regulatory perspective which can really bring forth this industry at parallel with some of the developed economies?
So regulatory is very important, but regulators should not see that they are only policing. They need to enable also. That's one area where we have not really learned well. But India was the very easy market. Anybody can just bring medical devices from anywhere and start selling it. It was a very common practice. You might have heard during the even pandemic time, oxygen concentrators were brought by almost all the businessmen, and several containers came and they were just selling freely. Now what government has done is that they have formed a one regulator by name CDSCO, and every product in the medical devices has to go through that, whether it's a class A, B, C or D. They have given time, though timeline was not really adequate, and the 30th September is the last date, and there are a lot of challenges. More than 500 applications are pending with them. But a very right thought that any product which is sold in the Indian market has to be tracked back. That product will have to have an approval from CDSCO, then only it will go in the market. So this is a very welcome move which Government of India has done, and I think this will improve our overall efficiency. It will also improve the there will be a lot of challenge on Indian manufacturers to build a product to that level, and the quality what they have set is actually higher than even C. We all know the C. Indian regulation has set norms. If you meet that, you'll be better than C, which means you can take these products globally outside. I just want to end this with one line that we keep talking about the how building resilient healthcare. It's a very time-taking thing. And we are doing a good job. I mean, it will not happen immediately. We have embarked on the journey. We have to have that patience. And in my view, government is really making a lot of effort. The amount of calls we get today, that what help you need as a manufacturer from us, how can we help you? I mean, those things are really very encouraging. And I think we are on the right path. And you will see definitely accessible, affordable healthcare in India. But it's a journey which will take, and we have a population. I mean, it's such a large population with so much low income overall. Those are the hindrances. But we are on the right path. Thank you.
Thanks, Sunil. And I think that's a great remark to close this session on. And as we draw this enlightening panel discussion to a close, I would like to express my gratitude to CII again for organizing this excellent summits, and all the distinguished panelists to bring forward your insightful and drawing your experiences and providing these insights. Thank you everyone for taking the time out, and may I please request everyone to proceed for lunch now. Thank you.
Just a minute, sir. I would like to kindly request Mr. Nilesh Maheshwari to present a token of appreciation to our panelists. Mr. Sunil Khurana, CEO and Managing Director, BPL Medical Technologies Private Limited. Dr. D.K. Gupta, CMD, Felix Hospital. Mr. Tarun Tripathi, Business Unit Head, Quidel Ortho. Dr. Sachin Gupte, Lead State Operations, PATH. Mr. Ravideep Singh, Associate Director, Creative Designer Architects. I would now like to kindly request Dr. Dharminder Nagar, some Yes. I would now like to request Dr. Dharminder Nagar to kindly present a token of appreciation to Mr. Nilesh Maheshwari, Senior Principal and Head, Public Health, South Asia, IQVIA. I would like to now call upon Mr. Deepak Nanavare, Head Marketing and Business Process, AAF International, EEMEA, CIS and SARC. Thank you, everyone. हाँ लॉक करो हाँ हाँ भैया